So you got one Asian, he got one Asian.
আচ্ছা শুধু পোস্ট এখন করে দেব তাহলে 9টা থেকে ওয়েট করে রাখা হবে WhatsApp করে দিলাম হ্যাঁ যেগুলো সব
আমি আমার যা যা করার সত্যি
আমাদের যে অ্যাক্টিভিটি আছে তাদের
all three of us.
Yes.
Orbita, why don't you come here? Nick can come here as well, and we will start the program together.
Yes, yes. Come, Nick.
Guys, why don't you take a seat? Thank you all on behalf of ISN and TTS to welcome you all. What I will do is, during the entire program, I'll tell you a little bit about what we are doing as ISN TTS here and everywhere else. Narayan, can you hear us?
Narayan, can you hear us?
Yeah, I'm listening.
Very good. Thank you very much. Narayan is once again from ISN. So Narayan, I'm just introducing the International Society of Nephrology and the Transplant Society, and because this is a conference very generously funded by them, you already know that. So I'm just making sure they understand that we're very grateful for them to fund this program. And I'll hand over first to Nick and then to Orbita. So Nick actually co-hosts the ISN TTS program at St. George's with me, and he will probably welcome you as well. So welcome once again.
Shukrat. Yes, I'm Nick. I'm that's what
Narayan, you can hear Nick has learned Bengali.
Yeah, I am listening, ma'am. It is but here.
Yeah.
Yes, it's a great honour to be here. Thank you for hosting us, and we very much look forward to the next few days with you here in Kolkata.
And Orbita.
Yeah. So, very good morning, students, Professor Dishen, Dr. Joyanta Basu. All are welcome here on behalf of International Society of Nephrology and TTS. We have been upgraded. The message of pleasure is we have been upgraded to A. We are liberally funded by International Society and TTS, and this year they have visited us. Next year we can arrange some students to go from here to there and make an observership of 10-15 days, which will be benefiting you in multiple ways. You can see the things that do not still acclimatize. We are not acclimatized to those things which are happening there, and later on can start doing that here. One of the programs that amazed me there, the DCD with their outcome and the swap that they are doing to expand the living donor pool, and I'm very much eager to expand the donor pool to adopt both if possible in our Indian scenario. So IPGMER may be one institute who can have a vision to witness that in St. George's itself. Thank you.
So shall we invite Professor Sen and Jonathan?
We'll come, we'll do it from here.
All right, okay, here you go.
It will be better visible from that end. Sir, you may call Dr. Narayan Prasad.
Good morning to all. Now I request Professor Dr. Narayan Prasad, Head of the Department of Nephrology, Sanjay Gandhi Institute of Postgraduate Medical Education and Research, Lucknow. Please, you can
First row,
deliver your lecture
should
on this topic.
Narayan should see fully. Huh? Hello, mic on na. Hey, mic on nahi.
Yeah, ma'am, can I share my presentation again? Because that is not that is it from the screen.
Yeah, make his presentation full screen.
Good morning to all. Now I request Professor Dr. Narayan Prasad, Head of the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, to deliver his lecture on this topic, renal genetics and kidney transplantation.
Meeting শুরু হয়ে গেছে পরে কথা টেক্সট করে দিন
Okay, can I proceed now?
ইয়া শিওর নারায়ণ
But still it is not full view, ma'am. Can you make a full view?
ইয়েস শিওর
So, should I start?
ইয়া
Someone will move a slide from your end, ma'am, because
Yes.
it's not
Yeah.
moving from my end.
Debru, you go there and move sir slide. আপনি ছেড়ে দিন
Okay. So, good morning everybody. Dr. Devashish Banerjee, great friend again back to India, Kolkata. So, thank you everybody. Thank you all representative from ISN and TTS there. So basically I have been given the task to speak on renal genetics. So we all understand that is how important it is in today's era. What does a patient expect to know from a physician? What disease did I acquire? They want to know the diagnosis. Why did it happen to me? Why did you give me these medicines? Will I recover? So is this possible to answer this question precisely only on the clinical grounds? Answer is clearly no. Can you move this slide? Move slide, please.
Next slide.
Answer is clearly no. So, in a human genome project that I am giving you a brief for how it evolved, it started in 1990 and completed in 2003 with a focus on identifying, mapping, sequencing all genes in the human genome. And it becomes 100% complete gap only 3 years before in 2022, and approximately 3 billion chemical base pairs of the human DNA have been mapped. We can just wonder approximately 20,000 of protein coding genes are in human genome. Most are identical among copies. So this is the reason why all humans looks like the human beings. And only slight variations cause some phenotypic changes, so that why I am Narayan Prasad, why this is Devashish Banerjee and some others. It also contains other non-coding RNA genes and pseudogenes and inactive copies of the genes, but are important for understanding evolutions. Next slide, please. So, foundation work on DNA sequencing that basically started with the discovery of the predicts Sanger's. Sanger's sequencing we all understand. That was started in 1970, but that was a very long time taking process. So since then it evolved, targeted strategy came in 2005, and 2009 was the very good era for the genomic genome sequencing project was pioneered in 2009. Then in 2009, whole genome sequencing was formally developed by NG and colleagues. And this was the year, the first time this whole genome sequencing came into the practice, and the first patient who was misdiagnosed with the Bartter syndrome actually has the congenital chloride losing diarrhea. We all understand these patients have a similar kind of the phenotype, hypoplasia, metabolic alkalosis. And so this was basically chloride losing diarrhea, and which was misdiagnosed. That was the first time when the first clinical diagnosis, first clinical use of the genome sequencing. Next slide. Next slide, please. So genomic, pharmacogenomic and precision medicines that we got, see the key achievement of this project was the free and open release of this genomic data to the public, fostering a new era of the data sharing in biomedical research. This is all freely available. Those who knows about the bioinformatics can go and make up multiple research out of this data. Genomics is used to diagnose kidney diseases. Pharmacogenomics helps in tailoring medication selections and dosing, and precision medicine an approach that tailors disease treatment and prevents an individual's unique characteristics, considering their genetics, environment, and lifestyle altogether. Next slide, please. So how is genomics and pharmacogenomics applied? Genomics, diagnosis of the genomic kidney diseases, disease risk assessment, prognosis and family screening. Pharmacogenomics, particularly used for optimizing drug selections with genetic variants, personalizing the dosings and reducing any adverse effects of the drugs. So in December, on December 18th, 2015, Barack Obama launched a bipartisan precision medicine initiatives. And that was the turning point for the move of this genomic and pharmacogenomics in precision medicines. And the theme was delivering the right treatments at the right time, every time, to the right person. And NIH was at the forefront of this initiative, helped to drive participants engaged data-driven research with the combination of the data on the biology, computation, medicine, genetics, and environmental knowledge all together. So precision medicine initiative was then, now it is popularly known as All of Us Research Program. Initial cohort included about the cohort of the 1 million participants, their health information and samples into the national database and biobank. And All of Us research project became so popular and it exceeded this 1,000 genomic project. And Genomics England, so the 1 lakh genomes in the scale and scope. That became very popular. So sub-aim of this precision methodology was the database approach. You have the information on the traditional clinical data, then transcriptomic data, metabolomic data, and metagenomic data. We can just imagine it was not possible to identify all microorganisms in your gut microbiota. This was all this evolution of the metagenomics which will identify all different kind of the microbiota. Next slide. So using genomics and pharmacogenomics, you can see one size fits all model was the current treatment scenario, which usually is the most of this us sitting in clinics need to do this. We give the particular same treatment to all. Some has minimal toxicity and gets success, has excessive toxicity, some has full failure. So then next slide please, next slide. One click. So when you have excessive toxicity, go back. Just go back. When you have excessive toxicity, treat with the alternative dose. When you have the failure, you can treat with the alternative drugs or dose. When you have full failure, the patient has excessive toxicity and the failure same time, treat with the alternative drugs. So this is all about the precision medicine. Next slide. So I am giving you some examples of the patient. This was one patient. One patient, 26-year-old, at IPGMER came with this oculocutaneous albinism. You can see from the figures. Just give one click more so that this video will run. Just one click. Okay. Okay, if it is not any noise. So this patient had nephrotic syndrome at 12 years. Go back. At 12 years of the age, treated by the local pediatricians with the temporal site steroids, EMI, mycoplasma morphine for 10 years without any response. He presented to us with steroid assisted nephrotic syndrome with biopsy finding showing minimal channel disease with possible FSGS. Patient had uncontrolled hypertension, has nystagmus, oculocutaneous albinism, sensorineural hearing defect, anterior lenticular conus. Next slide, please. So, what we have, when we have done the biopsy, after that, He developed a hearing defect, sensorineural loss by the age of the 15 years. They cleared in SRD. It has been shifted on maintenance dialysis. And you can see here, electron microscopy was very much suggestive of Alport syndrome. Next slide. So his brother was again the 26-year-old. This was the twin brothers of Loctanus albinism. Next slide. Next please. So no complaints of hearing loss before presentation. He was doing well and came to the ward to see his brother. He was totally asymptomatic. He came to meet his brother, and his mother had just told me that he has a little headache. So you can see here, this is the inheritance edited chart. There are the two brothers, and one was already admitted, other came to see these brothers. Next slide, please. So this is the story of his brother. He was otherwise asymptomatic. We tested him in the ward. He had hypertension, some necrotic proteinuria, anemia, advanced kidney failure, bilateral small kidney stone, ultrasonogram, anterior lentic conus, advised conservative treatment on follow-up, and he also developed ESKD and opted for knee transplantation. Next slide. So we have evaluated the parents also, both are carriers, here you can see, and on the genetic testing, what you can see, this patient has a defect in the tyrosine gene, which is responsible for formation of the melanin, or pigmentation. So this was very much pathogenic in this case, and fold A3 was also there, and this electron microscopy and other phenotype was also very much suggestive of the Alport syndrome. So there was no confusion. It was coming as a US, but we are very certain that this is pathogenic gene and the patient has Alport syndrome also. Next slide. So both SK and RK, both brothers, well, we have started workup for the transplantation. One was for the ABO compatible transplantation with father as a prospective donor. We all understand mothers are usually the carrier in this scenario. This is the X-linked derived. So father was the T cell cross match was negative, B cell cross match was negative, but there was some single antigen bleed. So you can see some of MFI agents, some of these donor specific antibody. You can see here MFI was quite high. RK has also worked up. Subsequently, we tested the mother. She had no any proteinuria, no any macroscopic hematuria. She was normotensive, so no abnormalities. So that is usually we used to take such a mother of Alport syndromes as a donor. We have tested for DSA by lygates that was all negatives. Next slide, please. So Alport syndrome foundation and other experts recommend that you can take mother as a donor if there is no proteinuria, normal hearing, normal kidney functions. Advance is usually more than 45 years or older females. And a biopsy sometimes should be done to see the kidney damage, but usually we do not do in the practice. Comprehensive genetic testing to confirm the diagnosis and thorough counseling for all potential risks for the donor and recipient. Both prevent transplantation. First SK, first brother, transplanted with the father on 31st of January 2024. Induction was anti-thymocyte globulin. There was some, you can see, the patient had some antibodies. So anti-thymocyte globulin, some plasma exchange has been done, desensitization protocol, what we follow at our place has been done, and the patient has been transplanted. The other, after some gap of the 5-6 months, mother came out for the second again we have transplanted with specific small inductions. Next slide please. Here you can see this family, Alports plus albinisms, oculocutaneous albinism in both brothers. Parents were totally normal. Rare instance of the two genetic variants according to different code 483 and plus tyrosine gene was affected in this patient, in brothers. So let's learn from this this study was early genomic study. We could have done when the patient was destroyed resistant, we could have avoided multiple immunosuppressions and their side effects in these patients. The genetics study provided confidence that probably if you have this genetically positive steroid resistant nephrotic syndrome, the chances of recurrence of the FSGS is minimal after transplantation. So that confidence also comes in. Another boy, 12-year-old boy with a steroid dependent nephrotic syndrome, again you can see. Give a click on photograph. Again, this boy also had nephrotic syndrome. Initially, a steroid dependent, subsequently we have seen there was a lot many cycles of the steroid CNI, rituximab had been given for this nephrotic syndrome. Patient had nystagmus, family histories, patient's elder brother died of the kidney disease, but nobody was knowing why this died. So we have planned for some genetic workup. Next slide. So here we can see the one brother died, his brother was affected, and what we can see there was mutation in the LAMP2. And we all understand this LAMP2 is associated with the nephrotic syndrome and autosomal recessive. Usually the autosomal recessive patterns are usually seen. So here again we can see next slide. So we have made this recent diagnosis of the Pearson syndrome, but it was not very typical of the Pearson syndrome. So sometimes the phenotype may be different. So human mutation in lamin Z2 has been described with this LAMP2 mutations. It is characterized by neonatal nephrotic syndrome, eye defects, macropolia, abnormalities of the neuromuscular junctions. But this boy has he presented late, usually either of the age of 4 years, more macropolia and more nystagmus, less more neuromuscular involved. So usually this phenotype was a little different. So the total of the 6 I'm just giving you one recent data we have published UKJ this year. The total of 650 pediatric nephrotic syndrome patients which were at follow-up at IPGMER. We have got tested for steroid assisted nephrotic syndrome and some genetic testing has been done. Amongst the participants, 64% have reportable genetic variants, and most common among the nephrotic syndrome, you can just imagine Pol4A genes. So it appears that the L4 syndromes in Indian scenario, if you have the steroid assisted nephrotic syndrome, and even if at initial stages there is no lenticonus, no bearing defect, but if you are going to test for the genetic test, this collagen genes turns out to be positive. So this was a major finding in our study. And we have also seen many of these patients when they are put on the CNI, they have either partial or complete remissions with many of the other genes mutations also. So it is not that if genetic mutations they are there, you should not try. We can try with the CNI. Some patients, we all understand there is some cytoskeletal stabilization with the CNI and can reduce some degree of the protocol. So this was the finding from our study. Next slide please. And you can see we have a code divided into the different inheritance pattern of this model mutation in steroid assisted nephrotic syndrome, autosomal dominant, autosomal recessive. What was the peculiar finding which is commonly reported in other studies or NPHS 1 or 2 genes? That was the rare finding. Only 2% of the NPHS 1 and 2 was there in our whole of this cohort. So it is looking like it might be an uncommon finding in Indian scenario. And this finding has been reported. Similar kind of this observation has been seen in AIMS data and data from the St. John's Bangalore. Next. I'm giving you one example of the adult nephrotic syndrome. This 46 years male has attention for 3 years, bilateral fetal edema, polyurine. And there were no confusion in the patient probably had nephrotic syndrome. Next slide. So 24-hour urinary protein was 9 gram per day, and you can see protein albumin was low, so we thought that we should go for the biopsy. Next slide, please. And next slide. So biopsy showed FSGS, kind of the pictures. This was globally sclerosed by this time, out of 40, and there was some foamy appearance, and there was some moderate kind of interstitial oxygen to the coffee also, and no immune deposit. So looking like this, it is the FSGS. Go ahead. Next slide. But look at this chart. This was a very wonderful patient came from Mumbai to us, and you can see the lower chart. One ESRD with biopsy was not done. This was biopsy A, but WT1 gene mutation was there. Second one, CKD stage 3B, biopsy has been done somewhere else, but that was diagnosed as IgA nephropathy, but subsequently WT1 genes. Third one, horseshoe kidney, nephrotic syndrome, CKD, 5 WT1 gene again positives. And this index is 46 years ESRD 55. She was showing FSGS, WT1 gene again. And other 26 years had CKD. So you can just imagine there are different phenotype of variations. One has a horseshoe kidney, other was showing some IgA nephropathy. All were common destroyed resistant nephrotic syndrome. And with this WT1 gene mutations were there. Next slide, please. So we have all the genetic testings. This gentleman has also WT1 gene mutation likely pathogenic. Next slide. So diagnosed as FSGS with moderate IPTA, no response to the features of the steroid toxicity, CNI, multiple CNI, tacrolimus, and many other drugs have been received. But patient was progressively land up in the ESRD within pneumonias, and patient is being planned for transplantation. But this genetic testing again gives us confidence that probably there will not be any recurrence in this FSGS kind of. So WT1 genes, if you were tumor suppressor gene, we all understand. I'm not going into the depth. So clinical manifestations of WT1 gene, you might have the different manifestations. We all understand from our MBBS days, it is associated with the Green tumor. It can have the Frazier syndromes, Dennis-Grass syndromes, disorders in parental development, and isolated WT1 nephropathy, acquired resistant nephropathy syndrome can also be seen. What was there in that index case. So WT1 genes, even in adults, sometimes if the patient is not showing the typical course, we should investigate this for the genetic testings, and you can find out some of the genes involved in causing this disease. That gives you the confidence that probably you are dealing with this, going ahead with this right directions. Next slide, please. So genetics and CKD indication family history is there, consanguinity is there, extrarenal manifestations are there, dysmorphic or syndromic features are there, CKD of unknown etiology, cystic kidney disease. Kidney disease at very younger age. Also some of the centers doing this genetic testing as far as nephrotic syndrome, childhood onset of the CKD. Lot many indications are there now. There we need to go into the depth, see, make the native diagnosis, diagnosis. Next slide, please. So clinical implication of the genetic testing is the direct diagnostic implications, implication of ongoing treatment, and implication for snake transplantation. Next slide. So genotyping and phenotypic assessment pre-transplantation. I'm just giving you example. A 30-year-old male had proteinuria of 2.8 gram, active urine septum, proteinuria of 3+, RBC of 3 to 10, serum creatinine of 2.8, normal CPC4 levels, ultrasonogram, as usual the patient presents late, daily borderline less than 9 cm, increased echogenicity, CMD loss, patient informed for the need of the kidney biopsy and associated risk. He refused kidney biopsy, and the kidney size is also borderline. Empirically, prednisone ML started with ESRD in 3 years, is now for the kidney transplantation, provisional diagnosis for the IPGMER Kolkata. Very typically made a diagnosis clinical. Next slide please. So genetic testing for the native kidney disease, ESKD of unknown etiology, early onset ESKD, family history of ESKD, and extrarenal manifestations are there. These are the common. Next slide please. Atypical hemolytic uremic syndrome, primary hyperproteinuria, FSGS, ATPKD, FOL1 genes, and the FOL1 genes are usually may not be required in Indian scenario because the data from IIT Chandigarh, data from Madras Medical College, and even we have research in our big series of example, we did not find any FOL1 gene mutation in India. So that is not very known fact that probably this is not in Indian scenario. Next slide please. So why do we need a pre-transplant immunogenetic workup? So I'm going a little bit about this further transplantation. Compatibility assessment, risk stratifications, treatment planning, and finally the patient selections. Next slide. So HLA testing for the kidney transplantation, usually we all understand by the August 2025, pharmaceutical HLA class 1 and class 2 alleles have been discovered. HLA might be someone else might be also taking on the class of this year. We know about the class 1 and class 2. We know about the epitopes on HLA class 1 and class 2 both. Usually class 1 has 3 chains alpha 1, 2 and 3 and beta 2 microglobulins, and in class 2 we have alpha 1, 2, alpha 1, alpha 2 and beta 1, beta 2. And the epitope is the place where antibody used to come and bind. So we should know that this is the epitope, and those antibody which used to come and bind this groove, the peptide binding grooves, so that all the antibodies bind is called paratope and is called epitopes. Just for the post diagnosis. Next slide. So usually the nomenclature of the HLA that has been put into the picture in 2010 by WHO, where HLA and it comes out. A is the gene and then separate is used. Allele, then specific proteins, then coding sequences, then non-coding sequences. And what is important to understand in HLA matching, which we need to do in clinical practice, that this father and mother HLAs are there. They come in the set, from the one set from the father, another set from the mother. Here for the example, either A1, B8 and BR17 from the mother, this is A2, B44 and BR4. So this inheritance comes in a set. So that helps you now day-to-day practice in matching direct with the parents, HLA matching all. Yes. So usually reporting, so many times we are confused with the digits of it. 2 digits reports, single digits reports. 2 digit reports is very common, and that 2 digit reports include alleles. 4 digit reports a specific HLA protein. 6 digit reports a specific HLA coding sequences. 8 digit includes a specific HLA sequence, including ultra-translated regions and some of the introns also. So usually in kidney transplantation programs, up to the 2-digit alleles is defined, and we do not have this required intermediate resolutions is good enough. High resolutions is usually required. If it is available, it is very good. If it is not available, then many of the centers in India do not follow this high resolution by MGS with the all 4 digits. The 2 digits are fine for kidney transplantation programs. Next. So we all understand that as soon as your mismatches go down, the survival will go down. So risk stratifications is very important for us. It is looking at the history, at the blood transfusion, pregnancy and repeat transplantation. Those who are involved in heart transplantation, So this is the one extra point whether it's prior exposure to tissue graft or left ventricular assist device. That is also a risk factor because in Kolkata there are multiple centers that means heart transplantation also. So that is another important point to understand. Next slide, please. So integrating HLA typing in risk assessment is very important. And giving you this here, you can see the wide spectrum. At the one end on the right side, high titer DSA, low cross match positive, CDC cross match positive. There is a very high risk of the acute rejections. As soon as you go down towards the blue line, the risk when there is no HLA antibody, if you have this single antigen field assessment or PRA done, there is no HLA antibody, risk for de novo response that becomes 30. And if it is HLA identical, which is very rare in our scenario, then there is very low risk for any autoimmune disease or chance of the rejections. So usually we have this spectrum of the testing now. So flow cytometric cross match, CDC cross match, then single antigen bead assessment, and then most of these high volume centers, these are all available, including at our centers, and then we can mix and match for the risk assessment. Next slide. So yeah. So we have cross match before transplantation, single antigen bead testing, cytometric cross match and CDC cross match. Usually we need to get it done. And when you have this highest sensitivity is there with this single antigen bead testings and flow cytometric cross match high, and the lowest sensitivity is there with the CDC cross match. And all identify anti-HLA antibody. So but definitely we all understand, I don't have the time too much to go into the depth of this detail of this different matching or finding of this NDHLA. Sometime else or someone else might discuss on these topics. Yes. So here comes if you have all three positives, there is no confusion, there is significant burden of the DSA, donor specific antibody, and high risk for hyperacute rejection. Confusion comes when one is negative, like the CDC is negative and your flow and SAB is free. Then definitely you have this moderate burden of the donor specific antibody, and some non-complement fixing antibody, it is quite possible. Complement fixing you can only test on CDC. That is not tested on the flow and SAB. So probably it is possible that some non-complement fixing DSA is there. If only SAB is positive, flow and CDC are negatives, then you can think of there is the lowest burden of the donor specific antibody. And false positive SAB can also be there due to some high background serum factors binding to latest beads, binding to denatured antigen, threshold for falling antibodies. And sometimes different serum used for the SAB versus cross-match testings. Sometimes it happens that in the laboratory, serum which has been sent for testing for the CDC was different and for the SAB was different. It is also quite possible because you test it at different point of the time. So everything should be kept in mind because the sensitivity of the SAB is very high. But CDC has a low sensitivity, but they detect the advantage of the CDC is you get by complement fixing DSA antibody. Next slide, please. So it is quite possible that sometimes SAB negative, but flow and CDC is positive. So again, now one of the new emerging factors are the non-HLA immunoglobulins binding on the cell surface of the lymphocytes, non-HLA antibody. So that if you have the facility, you can test for. Recently, we have tested in our lab, but this was very much discouraging. A lot of anti-HLA antibody we have detected in our staffs. When we have tested it, that really what we are going to do this, we have tested the patient who has a rejection, some of the patients do not have the rejection, and some we have as a control, negative control tested in our lab but that was non-specificity very high in some of our staff, normal healthy persons. So I don't know how to interpret this in the future. Next slide, please. So steps for immunological workup usually ABO typing, HLA typing, antibody screening, cross-match test, donor specific antibody identification, finally transplantation and outcomes. Next slide, please. This is my final slide. So this is my request. IPGMER is organizing ISN 2025 this year at Lucknow from 18th to 21st December. So I will welcome you all to register yourself. And if you are willing, if you have any problem in getting the registration or any accommodation or any problems, let me know. I will try to resolve. So thank you, ladies and gentlemen. Thank you for this opportunity. Thank you, Arpita ma'am, and all members of this Kolkata.
Thank you, Dr. Narayan Prasad, for a lecture on genetics and its implications and for the precision medicines that comes with it. If any students have got any queries or questions, is there any questions or comments? So, thank you, Dr. Prasad. There is no questions or any comments from the floor. So we close this session. Okay.
Narayan, I have a few, but I am not bothering you now. You will have to catch a flight. So we will meet in ISOT and I will resolve.
Okay, ma'am. Thank you.
Hello.
Our next speaker is Dr. Smita Dibbabir. He is the Associate Professor of Nephrology, IPGMER Chandigarh. She is our ex-resident and brilliant resident. And now I request her to speak on her topic, hepatorenal acute kidney injury. Welcome.
Thank you. Am I audible to everyone?
Yes, yes.
Shall I share my screen from here or somebody will be presenting this slide?
You are finding the share button there
Yes, I have shared.
and you can share. Then you can share it from your end. It would be smooth to glide.
Yes, yes, I'll be able to change my slides myself.
Yeah.
Okay. So are my slides visible? Should I start?
Yeah, sure. It's visible.
Yeah. Very good morning to everyone in Kolkata. Greetings from Chandigarh. It is always great to join Calcutta, my alma mater, and it's a pleasure to see my teachers. At the outset, I would like to thank the International Society of Nephrology, the Transplantation Society, and my alma mater, IPGMER, for giving me this opportunity to share my thoughts and words on hepatorenal API, a topic of my interest. So this shall be the outline of my talk. I will speak on API on cirrhosis test, its significance and how the various definitions of API have evolved over time. A little bit in brief about its pathophysiology, what are the management strategies in API, we should look at the prognosis, and then one of the most critical things in this
talk shall be how do we decide on simultaneous liver kidney transplant versus doing a liver transplant alone. And finally, how accurate are the assessment methods for renal function that we have, and what is the role of biomarkers. So as we all know, renal dysfunction is defined by its duration. Any injury that is occurring within 7 days is what we call an AKI. Its severity decides its stages. It is something between 7 days to 3 months. It is an acute kidney disease, and anything more than 3 months is a chronic kidney disease. A similar spectrum applies to cirrhosis. So cirrhosis is essentially a chronic liver disease, and it can go through various phases where it can remain compensated for some time, and the patients can experience decompensation as they go down. And the first decompensation itself portends a bad prognosis with a median survival of just about 1 or 2 years. Maybe in cases of compensated cirrhosis, in certain cases where the cause is hepatitis C, there may also be a regression of cirrhosis. So this understanding is essential that the state of cirrhosis and the progression of cirrhosis, along with superimposed acute and chronic liver failures, will decide the eventual course and the risk of kidney injury occurring in the set of cirrhosis. So let us look at why this renal function particularly is important in this way. Whenever an acute kidney injury happens in cirrhosis, it increases mortality not just in hospital during the same admission, but also at 30 days, 90 days, and even up to 1 year post the episode of cirrhosis. Moreover, the stage of AKI is associated with the risk of mortality. The higher the stage of AKI, more is the risk of mortality. So if someone had a stage 3 AKI, almost 70% of such patients will not survive up to 5 years. So AKI is of extreme importance in cirrhosis. How do we define AKI in cirrhosis, and how different it is from the other settings? So we know very well that the initial one, the initial uniformly accepted criteria was put in 2002, and this RIFLE criteria gave a kind of severity of AKI along with stages. Here, there was a baseline AKI, and the increases in creatinine over the baseline were used to define the stages of AKI. The problem with this was that many times baseline is not available. The other thing is that RIFLE took the duration of 7 days as a cutoff to call something an AKI. So clearly it was soon realized that we need earlier recognition of AKI to institute corrective measures. So the 18 in 2004 revised this, and the changes over 48 hours, as early as 48 hours in creatinine to diagnose an AKI. In addition, because a baseline may not be present, so any increment of only point will not be present in any sharp history of any nephrotoxic drug exposure or any evidence of structural kidney damage, which could be in the form of an ultrasound change or finding urinary sediments or significant proteinuria. So this is how the old and the new terms stand now. Don't call an HRS type 1 and HRS type 1, but instead it has become an HRS AKI. Then type 2 is HRS AKD, and CKD in the setting of cirrhosis is HRS. Now, the categories or the types of AKI as defined by the compartment of the kidney affected is more or less similar to other settings. That is, we have a pre-renal AKI, an extreme form of which is HRS AKI, the intrinsic renal and post-renal AKI. Some peculiar things that occur in cirrhosis can be IgA injury, are also common causes of AKI in cirrhosis. So this is just to elaborate a little further that within the pre-renal causes, in the setting of cirrhosis, laxatives and diuretics are often used, and they can predispose to a pre-renal AKI. Another thing peculiar is the presence of renal vein congestion, which can be present in the setting of massive ascites or a tense cystic, and the presence of portal hypertension and cardiomyopathy may also contribute to renal vein congestion. Although rare, one must be aware that midodrine can induce some kind of crystalluria, and these crystals can obstruct the excretory system, contributing to obstructive. Now, what happens to this after liver transplant is that more often than not, it can reverse, although a bit slowly. Only in certain cases where the damage is severe and tuberous sclerosis has set in, a complete reversal of kidney injury because of IPA may not happen. Hepatitis B and C, this primary injury to the kidney has become less common. Venous congestion also is something that is more hemodynamic and is reversible. Now, what happens because of what are the implications of renal dysfunction in cirrhosis? One is that, of course, it increases mortality, but the other thing is that the way severity of cirrhosis is defined is by using a score which is called MELD, which consists of parameters like bilirubin, INR, serum creatinine. So this makes it obvious that the presence of serum creatinine, anybody with a higher creatinine would have a higher MELD score. So MELD is a score that is used to decide on eligibility of a particular patient for liver transplant. Because of the addition of creatinine in this, it is an extra sad actually simple marker 3. So it was a high low protein and it was a high low protein, it's like this cultures%. The ultrasound showed normal size kidneys. So what do we do in cases like these? So typically we'll be doing all these routine investigations, but in addition, the ones of critical importance are to look at the urine microscopy, look at the proteinuria and the stool of blood. These are essential along with the ruling out structural causes by ultrasound are essential to consider the diagnosis of HRS in the setting of AKI. Some of the things that may be used is,
Exhaustive lecture on this particular clinically challenging situation. But since
I cannot hear. Yes, I can hear you now.
So thank you once again for giving us an exhaustive review of this particularly clinically demanding situation. Since we had already started running late, we won't take any questions or comments from the floor. We'll move to the next session, please. Thank you.
One line, Smita. One line, just one line. Thank you for joining us and giving this lecture. One important thing I want to highlight for students sitting in the back rows, that they should note this GFR related issue, MGFR versus EGFR, and how we could reach a more close EGFR to MGFR is the issue. And that in a resource limited setting, it's not very easy to do an iohexol or inulin based GFR. So the way you are proceeding, comparing the Indian standard, I would keep an eye on it, and we'll ask our students also to follow your publications, and that would be extremely helpful in Indian situation, as it would address the Indian population. And number 2 is, I am repeatedly finding now the liver transplant is happening in Kolkata as well as other places where people get LT done. They are being referred to us, and who are the Kolkata residents, and we nephrologists are often looking at the worsening creatinine and gradually moving up to the, I think when our students will be corroborating with the liver department, they will also need to see, and our faculties need to be part of the allocation system decision, that whether SLKT or LDKT liver transplant followed by kidney transplant, what would happen actually. That's why I kept your session and a little later the crosstalk session. So I would be happy if you be available in the crosstalk session as well. You may join as a participant. Please have a look at the timing if you can make time. Thank you.
Thank you so much, ma'am. Thank you. Always a pleasure to see you.
I think Shogatu will be asking you some questions.
Thank you, Ruby, for this nice presentation. So I have a query that in critical, are you listening?
Yes, I can hear you. Only if you could be a little louder.
Yes, actually when patients are critically ill, most of the time we resort to noradrenaline rather than terlipressin because we want to elevate the MAP. Earlier concepts was like elevating MAP gives the equal benefit of raising creatinine decline as terlipressin. Like US was not supporting terlipressin, their long time was advocating noradrenaline. And in ICU also you get to see that when RRTs are required, blood pressure further drops in this sort of patients. What is your take home that how do you manage such critically ill patients when we take for renal replacement therapy? And another thing is that what do you choose, online HDF versus traditional hemodialysis? Many such patients do not tolerate hemodialysis, and some studies do show that online HDF must be better. And as you show that bilirubin lowering therapy is not critically important, but when bile curves are concerned that whether such bilirubin absorption columns are useful when we deal with such patients. Thank you.
Yeah. Thank you, Dr. Shavalu. So it is true that these things are very difficult to manage, but what I want to highlight is that, see, once the creatinine is very high and the patient is in a dialysis requiring state, there is no role of terlipressin as such in the reversal in these cases. The response is going to be extremely poor. We have actually already sort of missed the bus, one would say. The early AKIs, when the creatinine is only mildly deranged, that is when the volume resuscitation and terlipressin comes in. Once these patients are dialysis requiring, we try to make a judgment whether this is an APM and if we treat the underlying cause. More often than not, it is sepsis of some kind, either SPT or a chest infection. And if that is addressed, then these patients may likely improve with their renal function as well. If it is HRS alone with the creatinine that bad, then the chances of recovery are minuscule. So occasionally we also counsel them about palliative care. If it is likely to be futile, then RRT is not going to, unless a liver transplant is forthcoming in the next week or so, there is no point of doing it.
Try to join the crosstalk session if possible.
I will try that. Thank you.
Thank you. Nice to see you. Every time I see you, I feel good. So next talk will be from Dr. Nick P. Anier, who will be speaking on pre-transplant genetic counseling again. We wanted both sides of the coin to be revealed, both sides of the coin to be seen, and Dr. Dipanjana Datto, who is a geneticist from Kolkata, will be chairing the session. Dipanjana, you should come here or... No, you come here. No chairperson in back row. She is a geneticist and helping us out in deciphering the complex genetic reports. I wanted Rajiv also to be here, but Rajiv is not here.
So, Shukra I'm Nick here. I'm a kidney doctor and I run the Inherited Kidney Diseases Clinic at St George's Hospital in London. So we've gone from here to Lucknow to Chandigarh and now to London. And when we hear from Victor, we'll be hearing from Mexico. So we're getting steadily further away from where we are. Should we just go to the next slide? Oh, yeah, so that's my statement of interest, but superimposed on a picture of the original St George's Hospital from 1733 back in London in Hyde Park Corner, which you must come and see when you visit. Next slide. Oh, right, so I thought I'd start with a case story, because of course there's always a risk of overlap when given the same title of talk as Professor Prasad. So I thought I'd just start with what I know that he won't have seen, which is our patient from St George's. And this was a 31-year-old Caucasian British man with end-stage kidney disease. He presented in end-stage kidney disease secondary. We subsequently found chronic tubular interstitial nephritis on his kidney biopsy. So he presented with a creatinine, a serum creatinine of 720 micromoles per litre. I forget what that is in milligrams per deciliter, but it's end-stage kidney disease, dialysis requiring. With and previously, so this was March 2022. In 2009, he'd had a creatinine of 103 micromoles per litre, which is already impaired, but it's shown that that over the course of 13 years, things have progressed quite significantly. And he'd been on peritoneal dialysis when I saw him in the inherited kidney disease clinic since July of that year, and he was currently on inpatient antibiotics for PD peritonitis and looking pretty miserable. And he was on a number of medications to support his end-stage kidney disease, including 1-alpha-galstol and quinine sulfate for his cramps. He works as an environmental technician. He's intellectually relatively normal, but still living, aged 31, with his mother, father, and grandmother, so a pretty busy house. And he did have a history of cocaine use once a week at weekends for some years. So next slide, please. Is that the next slide? Well, yes, possibly it was. Yeah, so next slide, brilliant. So no, next one. Perfect, so this is his family pedigree. So this is his mother and father with whom he still lives, and his surviving grandmother. There is a maternal uncle with end-stage kidney disease in his 60s, reportedly likely due to reflux nephropathy, and he'd had a kidney transplant around 10 years or so ago, so aged in his 50s, and he was starting to suffer some problems with his memory. Oh, fantastic, thank you. So, and this is him, 31, and he's got a 26-year-old sister who's currently pregnant. And his father has come forward, age 50, as a potential kidney donor. His urine is pretty clear, his urine dipsticks abnormal, and he's got normal kidneys. In fact, his mother also has clear urine and normal kidney function, and could also be a potential donor. But next slide, please. This is a CT scan of his abdomen, and we just picked up that he seems to have some nephrocalcinosis. And next slide, please. And the histopathology on his kidney biopsy, it demonstrated a significant chronic damage with a significant tubular incisional nephritis. There is some suggestion of a superimposed acute tubular necrosis, and the findings would be in keeping with a chronic tubular incisional process from cocaine use or an inherited condition. And next slide, please. And so we sent off a genetic panel looking at for all at that time known genetic associations with end-stage kidney disease of a young onset, and it demonstrated a pathogenic mutation in CLCN5. Next slide, please. So what is CLCN5? CLCN5, this is dent disease. A chloride voltage gated channel, number 5. It's an excellent recessive condition. In dent disease, we have CLCN5 and also OCRL1 pathogenic mutations. It's a renal tubular disorder characterized by proximal tubular dysfunction, low molecular proteinuria, hypercalciuria, nephrolithiasis, nephrocalcinosis, and progressive chronic kidney disease. It's generally speaking males that are affected, with progression to end-stage kidney disease between their 3rd and 5th decades. He's 31. He's relatively young, but this is in 30 to 80%. And whilst female carriers, who are generally obligate carriers, may show a milder phenotype, often they have no recognisable chronic kidney disease at all. Prevalence generally unknown, and in 2010 there were around 250 families affected, but I think this is another family. Next slide, please. And this is just a quick diagram to remind us of where the chloride channels are on the proximal tubular, proximal tubules of the kidney. Next slide, please. So, in terms of treatment, there are complications such as rickets or osteomalacia. A few patients with dental disease don't harbour mutations in CLCM5 and OTROR, so there may be involvement of other genes, and as we do more and more genetic testing, we're more likely to find these. Or it may be that there are just other epigenetic foci or other ways in which these genes may be involved that current sequencing technologies haven't yet identified. Currently, antenatal diagnosis and pre-implantation genetic testing is not advised. I suppose if we look back at his family tree, we'll kind of understand why. But the care of patients with dental disease is supportive, focusing on the treatment of the hypercalciuria and prevention of nephrolithiasis. Next slide, please. So we go back to his family history. We can see that this is an exome recessive condition. His mum is, in theory, an obligate carrier. We don't know about his two aunties with Down syndrome, but that would help explain the cause of end-stage kidney disease in his maternal uncle. And it would, in theory, preclude his mother from donating, as there's a certain risk of progressive chronic kidney disease in her. And then what about his poor sister, who is currently pregnant with what turned out to be a son? But it does reveal that his father is a good potential donor. Next slide, please. I think I've probably just summarised that already. So it established the implications of this genetic diagnosis for our patient. It established the cause of his renal disease. He was feeling so guilty that he was addicted to cocaine on weekends. And we found that it wasn't his fault at all. His transplantation would be an effective treatment because it's not going to recur in his kidney. It enabled genetic counselling for his mother, and once his sister had given birth, then we started talking to her. But that was quite a few phone calls, and it determined that his sister may not be able to donate as she'd otherwise want to once she gives birth. But it did confirm the father as a potential donor. So renal genetics is enormously powerful in this case and in so many other cases. And we should go to the next slide. So genetic kidney diseases are common. They affect 10 to 15 cases of adult end-stage kidney disease and most children on dialysis with end-stage kidney disease. There are over 600 genes associated with monogenic kidney disease, and the independent predictors of monogenic disorder, and we've heard this from Professor Prasad already, a positive family history, early onset, less than 25 years old, cystic kidney disease phenotype, the kind of cysts that you can see on the ultrasound on the CT from a mile away, they are more likely to be a monogenic disorder. To the point where sometimes we haven't been doing genetic testing at all. But from the previous case, you can see how effective, how useful it can be to do genetic testing in such cases. The presence of extrarenal manifestations which suggest another underlying genetic condition which is affecting not just the kidneys, but all other organs in the body. And all of these coming together should prompt genetic testing. Next slide, please. This is a summary of, I suppose, how to improve the whole of genetic testing in our chronic kidney disease patients. If you take a sample of patients with kidney transplant or end-stage kidney disease of any cause, you can enrich the likelihood of getting a positive genetic diagnosis from between, next slide please, between 9 to 50% amongst your patients with end-stage kidney disease. Okay, next slide please. So genetic testing techniques have come on an enormous long way, and Professor Prasad gave us a beautiful summary of how we started with the Human Genome Project back in 2000. And back then, our normal standard method of testing would be through single gene sequencing or targeted genetic panels. You'd identify a good phenotype, a cystic kidney disease phenotype, and you would pin down the likelihood this was PKD1 or PKD2, and this is really effective in well-defined clinical cases where there is a very strong suspicion of a specific monogenic disease. For example, Fabry's disease, TSC, which is a genetic condition which I'll talk more about tomorrow. Yes, definitely tomorrow. Primary hyperoxaluria, C3 glomerulonephropathy, etc., etc., etc. And also in familial cases where there are specific phenotypic patterns like cystic kidney diseases, tubulopathies, and steroid-resistant nephrotic syndrome. But whole exome sequencing, whole genome sequencing, and virtual whole exome sequencing using kind of multi-disease kidney panels are becoming more effective when multiple genes are potentially involved. And they're really effective at exploring all coding regimes of the genome in an unbiased manner, and detecting additional genetic diagnoses that aren't captured by conventional genetic testing. They allow for future reanalysis if there's new pathogenic genes are discovered, and far more efficient in high genetic and phenotypic heterogeneity of monogenic diseases. And so very effective in, for example, our case with a young onset end-stage kidney disease, what on earth is happening? Although if we think about it, if we put the nephrocalcinosis together, we put the young onset end-stage kidney disease, we'd have got there. But by applying an unbiased panel, we also got there. And as, next slide please, the cost of whole exome sequencing, whole genome sequencing is coming down from 2000, where we got there several $1 million, we've come down to portions of $1,000 per whole exome, and this is just coming down. And this is makes, next slide please, it much more widely accessible and therefore ever more transferable and translatable to kidney transplantation, which is why we're here. So the applications, I suppose to a degree I'm repeating what Professor Prasad says, but it's most effective by repeating what Professor Prasad says because it means that we have an agreed approach to what we're doing. We can influence recipient diagnosis and management. We can identify the cause of kidney failure. We can help predict the risk of kidney disease recurrence after transplantation, or not. We can inform the need for preemptive therapies before transplantation, before end-stage kidney disease, and after transplantation. We can help manage extrarenal manifestations of genetic disease, for example, with hearing, vision impairment in Alport syndrome, with cerebral vascular abnormalities in PKD, with hepatic sequelae in PKD, with TSC, with brain and renal and ocular and cardiac manifestations, and in VHL with extrarenal malignancies too. In donor risk assessment, we can identify potential kidney donors, particularly living-related kidney donors amongst the family, who would otherwise be identified as being at risk for developing kidney disease or other conditions. And we can help make informed decisions about donation and protect donor safety. And the example that we kind of brushed over a little bit because it's less relevant in Indian populations to our knowledge at the moment is APOL1 gene testing. Now, genetic studies have shown the significance of APOL1, particularly in high-risk genotypes found in individuals of African ancestry, which can influence both donor risk and graft outcomes. And we'll talk about that in a little bit more detail in a second with the help of some of my colleagues who are in London. And then the prospect of personalised medicine, as Professor Prasad indicated, by understanding recipient and donor genetics, transplant decisions can be more personalised, not only through the HLA typing, but also through pharmacogenetics, through thinking about CYP3A5 and gene mutations, how that influences transplant immunosuppression and also with gentamicin and mitochondrial genotypes as well, and how that gentamicin is so very widely used in kidney medicine, and the potential for causing deafness in that setting too. Next slide, please. So in the UK, we have the relatively newly implemented National Genomic Testing Directory, and this offers currently 13 different indications for genomic testing in kidney disease. These are the 13 indications, and you'll recognise them as common kidney phenotypes, including cystic renal disease, hematuria, proteinuria renal disease, CFHR5 nephropathy, membranoproliferative glomerulonephritis, renal tubulopathies, congenital abnormalities of the kidney and urinary tract, or CAPUT, where these are familial atypical HUS, tubulointerstitial kidney disease, hereditary systemic amyloidosis, nephrocalcinosis or nephrolithiasis, unexplained young onset end-stage kidney disease, probably my favourite panel to be honest, and most recently APOL1 kidney donor testing. So these 13 indications, and there are more, are all available free of charge to our kidney unit, but charged to the national genomic testing centres, allows us to do theoretical access to genetic testing for all of our kidney patients wherever they live across the UK. But of course, as you can imagine, the widespread genetic testing is mostly happening in the transplant centres, and less so in the peripheries out on the coast and in the smaller district general hospitals. So one of my many tasks is to help improve understanding of genetic testing and how to access it for our communities, our renal community out in the periphery of the UK. The whole genome sequencing indications are just 3: the cystic renal disease, proteinuria disease, and unexplained young onset end-stage kidney disease, where we have a lot of potential candidates. And only over the last 10 years, we have seen something like the swelling of cystic kidney disease go from just PKD1, PKD2 to the advent of several more novel, different cystic kidney genes, such as DNAJB11, IFT140, all of these other kidney, and these have been reported through unbiased genetic testing of patients with cystic kidney disease. And it's a fascinating field. Anyway, I should move on. Next slide, please. So genetic testing in kidney patients, I suppose broadly we're looking at is this disease genetic? And sometimes we just don't know. Sometimes we have a patient with no family history whatsoever, but the phenotype is suggestive, or we just have that clinician's gut feeling, or we have a patient's gut feeling that they would like genetic testing as well, which it offers a different influence in the kidney, in the clinic. Which test to use? We've already demonstrated that one, that using the simplified 13 indication National Genomic Testing Directory. And we talk to the patient, we talk about the risks of coming up with a definite diagnosis, because we're absolutely confident that this phenotype that they presented with is absolutely definitely a genetic condition. But at the same time, we also warn them of risk of getting no diagnosis whatsoever, or of getting a variant of unknown significance, which is entirely unhelpful to them and won't allow us to talk more about the disease at the moment, but maybe more information will come after someone's done a PhD for 3 years, or maybe even after that. So there is a risk of a clinical question, just hanging in the air for a long time, long after they've reached end-stage kidney disease, which is also an impact on them. And then we send a request, and that request can take 9 to 12 months to come back, mostly because of the laboriousness of the actual test, of the actual analysis. Next slide, please. So this is just a little bit about the APOL1 story, which I find genetically fascinating, but I recognise that it has less relevance in India at the moment. So APOL1 encodes an apolipoprotein, L1. It's evolutionary new, just present in humans and some primates. There are two African ancestry-related APOL1 gain-of-function haplotypes called G1 and G2, which confer innate immunity to African trypanosomiasis. And so here we have a kind of environment and genetically influenced evolution of these G1 and G2 haplotypes, which then, whilst they confer improved immunity to trypanosomiasis, have also confirmed an enhanced likelihood of associated kidney disease. And this kidney disease can be of almost any phenotype, of proteinuria, just progressive chronic kidney disease, of HIV-associated nephropathy. So there is a 7 to 10-fold risk in the high-risk genotypes of G1 and G2, or G1G1 or G2G2 haplotype patients. 7 to 10-fold risk of non-diabetic hypertension-associated end-stage kidney disease, 15 to 20-fold risk of FSGS, and a 29 to 89-fold risk of HIVAM. Next slide, please. And so these high-risk APOL1 genotypes in donor kidneys are associated in the recipients with faster allograft failure, and in the donors with more rapid decline of eGFR and an increased risk of end-stage kidney disease. The risk of the high-risk APOL1 genotype in recipients is slightly less clear. So currently, the indications for APOL1 genetic testing on the National Genomic Testing Directory in the UK are solely for testing for potential living kidney donors, where the individual being assessed for living kidney donation, the individual is being assessed for living kidney donation. Both of the individual's parents have African American, Caribbean or Brazilian heritage, and the individual has undergone counselling about the genetic testing. Next slide, please. And so we have implemented this model at St George's with our kidney transplant service, and our colleagues Janice and Richard have compiled a case series of 11 patients who we've tested so far. And next slide, please. Oh, next slide, please. Sorry, I could dwell on the detail, but the broad speaking, we've done a small number of patients of APOL1 testing, and around about 30% of them have high-risk genotypes. So 30% of potential donors worked up for end-stage kidney as potential donors for their relatives have been assessed as being high risk, and that has halted their transplantation, but it has allowed the other 70% of transplants to go ahead. Next slide, please. And oh dear, sorry, the slide's a little bit untidy. But broadly speaking, we are managing to turn over the results for this relatively simple genetic test over 52 days. So it is not mutually exclusive to proceeding, it's not slowing down the course of transplant donor workup, where the standard wait of 9 to 12 months for other genetic testing indications really would delay proceeding with transplantation. So next slide, please. And I was going to talk a little bit more about pharmacogenomics, but I suppose broadly we recognise our colleagues, Professor McPhee, previously about 10 years ago, has done pharmacogenomic testing looking at CYP3A5 mutations, the prevalence of those amongst African patients, looking at the question of why some of our African transplant recipients are requiring considerably higher doses of tacrolimus than others. And it turns out that the CYP3A5 mutations can be associated with a requirement of much higher doses of immune suppression, which allows us to increase our baseline immune suppression for those patients. Let's move on. And similarly, genetic kidney diseases can prompt screening for extrarenal complications, and I thought I'd just kind of highlight the importance of extrarenal screening for extrarenal complications amongst PKD1, PKD2 patients, TSC patients, VHL patients, and steroid-resistant nephrotic syndrome. We mentioned WT1 variants a little bit earlier. Mitochondrial diseases may be associated with an increased risk of post-transplant diabetes alongside those patients with cystinosis and HNF1 beta mutations as well. Next slide, please. And of course, genetic kidney disease may dictate a risk of recurrence post-transplant. So those patients with FSGS mutations in polycin, in atypical HUS with DPKA, KE and CD46 mutations in C3 glomerulopathy, and in primary hyperoxaluria, all enhanced risk of recurrence in transplantation without appropriate treatment. And that can help determine what we do post-transplantation. Next slide, please. So there are lots of pros and cons of genetic testing. In the American College of Medical Genetics definition, a positive test result is defined as detection of a pathogenic or likely pathogenic variant in a gene that matches the mode of inheritance and the phenotype. And the classification of these variants as pathogenic or likely pathogenic, though, is a dynamic process, and it changes with new discoveries. So one day you might have a variant of unknown significance, the next day you have identified a whole other family, or an extra member of the family with the same mutation, and you are ever more convinced that this variant of unknown significance is likely pathogenic. A negative test result, therefore, should not provide that reassurance that the Mendelian disease, kidney disease, has actually been excluded. So suffice it to say that we are trying to make sure that providing a correct diagnosis is more important than an incorrect diagnosis. An incorrect diagnosis can lead us down the garden path and make us give incorrect communication to our patients, which is dangerous. There's a high risk of certain variants of unknown significance reporting, which can cause, as we say, incorrect diagnosis, particularly in the absence of interdisciplinary contact between the clinician and our geneticist, which is why it's so important to have to improve training of all of us, so that we all understand kidney genetics and also then know when to call for help. And also to appreciate as well that the knowledge of the carrier status or non-carrier status for a genetic variant can have a negative psychological impact on the patient and family members, or for our patient, our 31-year-old environmental technician, which was another way of saying he was working as a binman, but he was so guilty that he had caused his end-stage kidney disease, and that genetic test result completely just lifted the weight off his shoulders, but it put an enormous weight on his sister, who was just about to give birth to a son. This is just to say that there are 5 different classes of variants, either benign, likely benign, variants of unknown significance, likely pathogenic, or pathogenic. And as you go more into the red zone, you're a bit more confident of what you're saying. Once you go into the yellow zone, you're just not sure, and you need to do more work. You need to seek for help. Next slide, please. And this is just to explain that it gets ever more complicated in our interpretation. And next slide, please. And so I thought I'd finish by coming to a different patient and just saying how it is dynamic. This is a 45-year-old Sri Lankan lady who had a clinical diagnosis of ADPKD. There's a positive paternal family history in her father and her brother. There's also thalassemia trait, there's old TB, lymphadenitis, diagnosed 1997. She's heterozygous for factor 12 deficiency. She works as a bank administrator, she hasn't been doing cocaine those weekends. And she's got multiple cysts in both kidneys found over 10 years ago on ultrasound. There's no MRI scan yet to assess the total kidney volume, but we do know that her late father did progress to end-stage kidney disease and died for 3 years. He died of his third stroke, age 60, having had a lengthy history of smoking and alcohol abuse complicated by liver disease. So whilst she didn't smoke cocaine, her father definitely did abuse other drugs, legal, and her older brother, 42, with ADPKD, has liver problems, is also a smoker, has 2 children aged 7 and 3, and also drinks a little bit of alcohol, as did his father. I don't think we have a genetic test for alcohol abuse as running in families. I think that's probably environmentally influenced, but we should move on. Next slide, please. So her ultrasound is fairly, it's clear. There are cortical cysts, multiple cysts in the cortex and on both sides. Next slide, please. And her kidney function is relatively stable, but there is a hint over the last 5 years of progression of her serum creatinine. Next slide, please. And here is that family history where her late father, here, and her brother, oh, that's not a brother, it is her brother. No, sorry, this is the patient, that's the brother, with a wife and 2 children, and then a sister who's dug her head in the sand and hasn't wanted to be screened at all. And next slide, please. So we've got a fairly convincing family history of an autosomal dominant picture, and that initial genetic test results come back in, when was it, mid-2022, and it's shown is negative. I talked to our genetic scientist and he said, I think there might be a variant of unknown significance in DNA JB11, but it's likely benign, so I'm not going to report it. So we went through the MBC and thought, oh, this is a very clear, beautiful autosomal dominant picture. We've got a very clear ultrasound, and I mean, we can't test the deceased father anymore. We could test the brother who's got the children, but the brother who's got the children is in between drinking and juggling the children, so he's not really interested in doing genetic testing, so we have her. And she is very driven. She is saying, I'm sure there's a result here. Anyway, there wasn't one. Next slide, please. So no established cause of disease. It doesn't exclude a genetic diagnosis. Doesn't enable genetic testing, screening for ADPKD in her relatives, in her brother, in her brother's children. It doesn't preclude tolvaptan treatment if that's applicable, and you can see there is a hint of her kidney disease progressing. We can direct her to PKD charity, which is our local UK-based PKD charity to help support the patient with her treatment and that likelihood that she will progress over time, as her father did, aged in his 50s. And we can recruit to RADAR, the Renal Rare Diseases Registry, which allows us to take all patients with rare kidney diseases and monitor their progress. Next slide, please. But we did, when we got the negative sample, the negative result, pass, because of the strength of this phenotype, we pass it down the diagnostic discovery pathway, which is essentially a genetic testing pathway which is outside of the front line of the people that have got the 1,000 results to analyse in front of them and have absolutely no time to look back at the old ones, trying to undertake PhDs with very convincing phenotypes, but no negative result. We pass it down there, and lo and behold, gosh, it was kind of middle of last year, so June 2024, so another 2 years down the line, we did identify a likely pathogenic mutation in PKD1. So next slide, please. This is pretty much the last slide. So we do now have an established genetic cause of disease. It allows us to, we were always able to use trorbaptor if we needed to, but it allows us to screen. It allows us access for PGTM, of pre-implantation genetic testing for monogenic disease, for her nieces and nephews when they come of age. Remember, there are only 7 of them at the moment. And we can do so much more. And the patient is reassured that what she was convinced with all along is that I have a genetic condition now has an affirmative result. Next slide, please. So in summary, renal genetics in transplantation, advances in next generation sequencing have made genetic testing more accessible. It's allowed us to improve the accuracy of diagnosis, to improve access to treatment for primary diagnosis and transplant planning for recipients. It's helping us to guide donor selection, and there is that prospect of personalising care for patients with inherited kidney conditions. And there is an increasing role in kidney transplantation, which is inevitable. So my role is to help develop understanding of genomics amongst nephrologists, as a mere nephrologist myself and not a geneticist, but to then make it more accessible for our patients, and therefore to apply it in all fields in nephrology. Next slide. So that's it. Any questions? Yes.
I have 2 questions actually. One is that what you did in your second patient was basically a cascade testing. So in these cases, like right now, aren't you using the whole genome? Like in UK right now, the whole genome is being used more and not the whole exome, right? Like you are using the genome, and in genome normally we would get such deletions. So what is the norm right now? Like, are you going with a whole genome background, or you're going with a whole exome background?
So it's a whole genome sequencing, and it was actually in 2022. But what it allows us to do is to look through. I mean, there are only relatively few reads in the whole genome sequencing of 100 to 200. Sometimes it's whether or not we're doing enhanced reading, as we do with TS, because it's a slightly more complex gene and there's a slightly higher prevalence of mosaicism. So if you've got 1 to 2% mosaicism, then 100 to 200 reads is only going to pick up 1 or 2 findings. So if you do enhanced reads, you're more likely to get
the CNVs will get more, and like we can actually detect more CNVs if we do an enhanced read.
But of course that's not widely used in.
Okay, so in general you are still doing a cascade testing. You are first giving the basic one, and then if needed, then you are scaling it up to the higher.
And the problem is that we have a number of patients who are coming with no family history, with cystic kidney disease. The genetic scientists may be blind as to how very characteristic their ultrasound or MRI report might be, and therefore they haven't got enough information to say, should we go and invest in enormous amounts of time in just testing this one patient. So our role is then to ensure that the HPO terms, the human phenotype ontology terms, are accurate, that we make sure that before we tested, we counsel the patient appropriately.
The clinical diagnosis is as accurate as
Absolutely.
possible.
Yeah.
So my second question is something to do with that only. So in cases where we are getting no genetic report, because we know the highest can be 60%. In 40% of the cases, even if there is a family history, we still might not get a variant. In those cases when the cases come up for transplant, so what would be your counseling and how would you proceed with that?
Oh, well, that is wonderful, and I think we just have to be very bespoke about it. We have to recognise, and so I think that when we're convinced this is a genetic problem, we don't have a genetic diagnosis. We know that it will come at some point, but we don't want to prevent them from proceeding with transplantation. then we're I think dealing with risk, really, aren't we? Predominantly with the risk of a parent or a relative also having a similar condition, and there are some that would like to donate regardless, and there are others who would rather shy away if the risks are too high. So it is very, very bespoke. But of course, the more that we involve everyone in the discussion, the more likely everyone would have come up with the same answer.
Yeah. So in these cases, do you actually have a medical legal, because it can also lead to a medical legal issue. So do you actually have any kind of medical legal protection or any kind of form or disclaimer that you give to the patients to say that, because there are some cases like say I'm 20, I want to donate, I might get a disease at 40. So, which I am not thinking right now. So, is there any kind of like counseling? I understand, but any kind of medical legal protection that you are taking as a second layer?
I think not over and above our hospital legal protection, but we do, as a hospital, pay quite a lot of money to the legal department for protection, and we document everything as clearly as we can. And the consenting process is as inclusive as possible. And I will regularly be in touch with Richard, with Janice, about various cases that where we're not sure. So it is very much our transplant donor workup physician who is taking on that risk, taking on the information from all of us, whether or not we're geneticists, nephrologists with interest in genetics, and assessing, also whether or not they have they're going to it with the right reasons behind it.
And one very small question. I don't know whether it's a valid question or not. With PKD1 and PKD2, often we get a second mutation. Like there is a pathogenic one, and then we get a VOUS, which in many papers right now is saying these spontaneous mutations are also modifiers. And when we test the family, sometimes what happens is that the father, there's a lineage, but the mother probably has the VOUS and she still does not have the disease. So in these cases, picking up donors, would you use the VOUS, would you use the mother's kidney, or you will not?
Just pushing. I think the answer is probably not, just because we're going to struggle medically, aren't we, on that basis. I can think of one. We could go on. We should probably talk after.
Yes, please. Yeah.
One ADPKD1 and HNF beta in mother that we got from South India. And it was a very complex interaction, and ultimately the mother could donate because she is less riskier donor. So mother.
I think in these cases, being bespoke, you have to give out all the risks and
I will actually bring this to an end because poor Victor is
Yes.
Yes.
And it's nice that we were not prepared, but Narayan dealt with the CGN genetic disease, and he dealt with cystic and CIN related genetic disease.
Brilliant.
Thank you, Nick. It was a very nice lecture.
Thank you very much. So we will move on to a completely different topic, and I just wanted to make sure before I introduce the topic that you're sharing the screen with Victor. Is that right? Can he present? So Victor, if you could share your screen, that would be great. Now, I'm a kidney doctor, but it's a pleasure to introduce this whole topic about cardiorenal and cardiokidney metabolics. And I'll tell you what will happen in the next 1 hour or so. We have amongst us Dr. Victor Hugo Gomez Johnson, who's going to be speaking from Mexico City, and he's a kidney doctor. He will be talking about the cardiorenal clinic in Mexico City, followed by Dr. Isaac Chung, who's also a kidney doctor, and he will be talking about the cardio-kidney metabolic service in Southwest London. And then we have amongst ourselves actually a cardiologist, Professor Subra Banerjee, who's going to talk about the proposed cardio-kidney metabolic care in the Indian setting. So, Victor, are you sharing the slide? Can you hear me? Can you speak, Victor? You're on mute. Victor, can you speak? You're unmuted, I think, now.
Can you hear me?
Yes, we can hear you very well. And can you share your slide?
Okay.
So as I mentioned, Victor is actually a kidney doctor speaking from the National Institute of Cardiology. So he works in a heart place, but he's a kidney doctor. And there you can see him, and he's going to share his experience about cardio-renal care in Mexico City, in Mexico. We can see you very well, Victor. And I'm sure you're trying to share your slides now. And whilst he's doing that, just to give you why we have chosen this topic is, diabetes is on the rise, and obesity is on the rise. As a result of which, obesity and diabetes-related kidney disease is on the rise. And when you put the diabetes, obesity, and kidney disease together, what you can see is the heart disease is on the rise, and it's going to be a major epidemic, not only for I'm talking about the United Kingdom and Mexico City here, but also in India. So we need to all understand how we're going to tackle this epidemic, how we're going to make sure that we provide care to these patients, which will be numerous across different countries, different continents. How are we going to provide? What will be the model of care? Who's going to be managing these patients? Will it be a kidney doctor? Will it be a heart doctor? Will it be a diabetologist or obesity expert? Or is it all of our responsibility to take care of them? The other thing we should not forget is these patients do suffer quite a lot because they move from pillar to post. They go to a kidney doctor, they're prescribed medication, then they go to a heart doctor, those medications are stopped, and they also have a primary care physician who is obviously looking after them and prescribing their medication. So these patients really travel between doctors quite a lot, as a result of which their care is often poor and they don't get the medicines they need to help them to survive longer or perhaps have a better quality of life. The other thing to emphasize, again, Victor, I'm just speaking because you are trying to share and we haven't been able to see your slides yet.
Yeah, I'm trying to share the slide.
Ask him that whether he finds the share
Let
button
me
or not.
see.
Can you see the share button?
Okay, it's because I'm trying to share, but okay, let's see if this can work.
In the bottom toolbar.
Yes, you have started presenting. You can see your slides. If you can put it on presentation mode, that will be great. But if you can't, that's also okay. Yes, I think we can see
that's
this.
it, right?
Okay, Victor,
Got it.
you have been introduced. Thank you very much. I know it's past midnight for you, so sorry to keep you awake. And the floor is yours.
Don't worry. Yeah, thank you. Well, thank you. Sorry for the delay. I'm struggling with the sharing of the screen, but yeah, I will talk about the implementation of care in heart failure and chronic kidney patients. And I'm the head of the cardio-renal clinic here in Mexico City. So, okay, so why this topic is so relevant? Well, because obviously
Conium, of course, it's not still available, or any other costly anti-hyperkalemic therapies like Paciromar, but I am doubtful that how we can implement it for the common good.
well, for example, in the public health system in Mexico, the Lokelma, or well, we already have Lokelma in Mexico, but it's not really easy to have Lokelma because it's kind of expensive, right? We can use it in the private health system, but in the public health system, it's really.
Thank you. Any questions from anybody?
I like to say hello to Isaac. Hello Isaac, Arpita here.
Hello.
We met in St. George's days.
Yes.
So, very nice talk, very encouraging, and the last slide is most appropriate for my young students because they indulge a lot on your sugar in cola.
Actually, let me ask you a question to the audience. Who believes in a sugar tax? Who wants to pay a bit extra if you buy full fat or full sugar Coca-Cola versus Zero Coke? Raise your hand. I believe in it. 1, 2, 3, 4, 5. Majority doesn't. This is the amazing thing. So majority like to drink full sugar Coca-Cola rather than normal Coca-Cola. But look, as a society, we have a responsibility too, because there will be a tsunami of cardiovascular syndrome, and we need to do something in the society. Nick, did you have a question? No. Subro has a question. Subro will be the next speaker, Professor Subro Banerjee, and he's a cardiologist. So we have a cardiologist amongst us, and he has a question for Isaac.
Hi, Isaac. It was a great talk. You can hear me? Yeah, this is Subro Banerjee.
Yes.
I think I agree with you, and that's really important, that we have to focus on the stages 1 and 2. I mean, when it's 3 and 4, the CKM stages, we are far advanced. So that's one. And secondly, most important players in this field, I think, are the primary care and the primary care physicians, because that's when things start. So if we can catch them early, and so it's our duty to make the primary care physicians aware of the CKM syndrome, and if we can stop it there, simple things like about why we should eat a lot of sugar, what's the necessity for doing exercises. So this starts with the primordial prevention, and I think that should be the future of CKM care all over the world. Thank you.
Thank you, Subro. I completely agree.
Obesity reduction.
Obesity reduction. Well, if you exercise and eat less sugar, obesity goes down. So, can I now invite Subro? Subro, do you want to come up to the podium? And is your presentation ready, Subro?
I hope so. Is it?
So, Professor Subro Banerjee is a cardiologist, and he works in the Apollo hospitals. He has a long-term interest in the overlap between the kidney and the heart, and his talk would be mainly highlighting what we need to do in a setting like India, managing the tsunami of cardiovascular metabolic syndrome. Subro, do you want to start while your presentation is coming on?
Yeah, so good afternoon. Thanks for inviting me here. I have a little bit of pain in my neck, so that's going to be a little bit difficult for me to face the slides, but I'll manage it from the other side. I think, yes, this is an important subject which has been very much neglected till recently. The subject of CKM or CRM, whatever you call it, cardio-kidney metabolic or cardio-renal metabolic syndrome. And we know now that the components, that's components like, it's not only just hypertension, diabetes, and the kidney problem, it's also like obesity, and so these things are actually very important, and they have to be taken care from very early age so that we do not develop this syndrome in the first place. Okay, so can I change the slides for you, or use
Is there a pointer?
Okay, so you're going to change the slides, right?
There is a slide changer as well. No?
Okay.
Oh, yeah.
Slide changer. Oh, that's right. Hang on. Okay, so okay, so what is cardiorenal syndrome or cardiovascular kidney syndrome? Well, in brief, it's a health disorder attributable to complex interplay among obesity, diabetes, chronic kidney disease, and cardiovascular disease. And these diseases have shared risk factors, shared pathogens, and shared therapeutic options. And other comorbidities may often exist, such as MSLD, cognitive dysfunction, obstructive sleep apnea, pulmonary disease, and even cancers. Now, while each of these components of CKM is associated with increased risk of mortality, the risk is much more if all the components are combined. And CKM syndrome is a worsening public health crisis with significant mortality and morbidity and economic burden. So therefore, an early detection, integrated preventive approach, and targeted interventions are crucial for prevention of these diseases. It's not working? So if you can, yeah. So these are the components of cardiorenal syndrome, and since it hasn't been discussed since this morning, I'll just quickly go through it. There are 5 stages. So stage 0 is when there is no risk factor for cardiorenal syndrome. Stage 1, when the patient has either excessive or an abnormal adiposity. And what is excessive? Well, of course, you go by BMI, though we know now BMI is not an exact, the best, the measure of obesity. Probably better would be waist circumference or a waist hip ratio or even a waist height ratio. Now, abnormal, what is abnormal obesity? Abnormal adiposity. That means there is this is a dysfunctional adiposity. And you would have some features, for example, you can just have hyperglycemia. You could be a pre-diabetic. So what stage 2 then? Stage 2 is presence of metabolic factors, for example, hypertriglyceridemia or diabetes or hypertension, or it could also be metabolic syndrome or even CKD stage, patients who has developed CKD. But would be moderate or high risk, not very high risk. Now, next is stage 3, which is actually presence of subclinical CVD in overlapping with the CKM risk factors. And subclinical CVD, as you know, it could be coronary artery atherosclerotic, or it could be heart failure, or it could be risk equivalence. And by risk equivalence, we mean is very high risk CKD, or it could be those who are at high risk of cardiovascular events, and how we find them out is something we are going to discuss later. Or it could be the stage 4, when clinical CVD is present, overlapping with the CKM risk factors. So these are the 5 stages we are going to talk about, and what is important is they have shared underlying mechanisms such as insulin resistance, inflammation, endothelial dysfunction, glucolipotoxicity, neurohormonal activations, and hemodynamic alterations. Okay, so now each of these components of the cardiometabolic syndrome, that's how you can say the component risk factors, there are societal guidelines for managing each of these risk factors. For example, there's societal guideline for dyslipidemia, for hypertension. So the question is, as we have individual societal guidelines, do we still need a common practice recommendation? The answer is yes. Firstly, because we know that the presence of a number of diseases in the CKM syndrome actually increases the risk of morbidity and mortality. But this is something which is often ignored in the societal guidelines. They do actually talk about a particular disease entity, say hypertension or dyslipidemia, but really do not give us some guideline about what to do when a multiple risk factors are present. So presence of a common practice guideline would be important. Similarly, an individual may present to any of the specialties first. They can present to an internist or an endocrinologist, nephrologist or cardiologist. So, but then the treatment would differ. I would treat him from the viewpoint of a cardiologist, but not from a nephrologist. So if you have a common practice guideline, then that would really be useful so that all the patients get similar treatment. And after all, these patients with CKM would need a holistic and multidisciplinary and interdisciplinary approach. So if you think about it, then of course, having a common practice guideline would be really useful. Now, do we need a country-specific guideline? Well, that's also important because each country has its own share of problems and specific healthcare challenges. Now let's look at the challenges in the healthcare system in India and why do we need India-specific treatment. Now, see, one of the difficulties in Indian healthcare system is the delivery of care. And we have to deliver the care to a population more than 1 billion. who may be diverse linguistically and socioeconomically and spread over a large area. And we do not have the infrastructure to deliver the service. So this is a major impediment or a challenge to Indian healthcare system. And then look about the inequality of the healthcare. More than 70% of the population is actually, they stay in the villages or the rural areas where you do not have anything apart from primary care centers. And here, I mean, these primary care centers, we know they're understaffed, they do not have many of the amenities, and their services are overstretched. Thirdly, if you think about the health insurance, I mean, till some time ago, probably more than 80% of the patients, not probably, this is not the data we have, that more than 80% of patients actually were not covered by health insurance across India. Now, recently, after some state schemes have come in, probably this fraction has changed, but I don't think to a great extent. And the literacy level is also somewhat low, and this resists adoption of, and this resists adoption of changes. And if you look at the level of providers' knowledge, that's also not always what it should be. And there's a gap between providers' knowledge and actually, what is provided. And unfortunately, we do not have strict quality control measures. That also is a major challenge to our delivery of care. And then we know there are two parallel systems operating at the same time. One is the government funded public health services in the public hospitals, and at the same time we have private hospitals where actually the treatment that we give depends on the affordability of the patient, whereas in the government hospitals, such as here, it depends on the budgetary allocation for health. So there are so many different things we have to consider when I have to think about delivery of a care service in our country. Now, if you look at CKM and the South Asians, they are different from that in the West, and why? Of course, how? And of course, we have an earlier onset and a worse outcome. There's a huge atherosclerotic burden. The inflammation and insulin resistance play a greater role in the development of the disease in our population. And there is a high prevalence of hypertension, diabetes, metabolic syndrome, and a unique dyslipidemia, which is characterized by high triglyceride, low HDL, and high lipoprotein levels. And we know that the prevalence of stroke is higher among the Asians than compared to the Caucasians. The central obesity with a normal BMI is also a phenotype which is not very rare in our population. Now, what about the prevalence of CKM among Asians? Well, unfortunately, we do not have any robust data for prevalence of CKM in India. But if you look at the other Asian countries, for example, Taiwan, you will see that with prevalence of CKM increases with age, and above the age of 80 years, CKM of stage 3 or 4 is prevalent in more than 90% of the population, almost nearing 100%. And another interesting thing is, as age advances, the prevalence of CKM 1 and 2, they gradually go down, and 3 and 4, that is the more advanced stages, they actually go up. So if we have to really catch the disease and tackle it, when we have to catch them young. Now, similar statistics you would see in the Chinese population as well. Now, how do you approach the CKM disease? Of course, you have to screen them, that's number one, and then determine the stage, because what it will do depends on the stage, and then you have to predict the risk of cardiovascular events. So risk prediction, and fourth is prevention or treatment of the disease. It depends, of course, on the risk of a particular individual. Now, regarding screening, whom do you screen and what to screen? Now, whom to screen? Your American Academy of Pediatrics says that you should start screening for CKM at the age of 3 years or more. I'm not sure whether that's going to be very practical in the Indian populations or not, but as an adult cardiologist, I would suggest that patients 20 years or more should be screened, ideally, and at least those who have at least one CKM risk factor. Now, what you're going to screen for? Of course, history is very important. History of diabetes, hypertension, dyslipidemia, CVD. You have to look specifically for symptoms of CVD and not just coronary artery disease. peripheral artery disease, history of stroke and all. And you have to look for risk enhancers, such as chronic inflammatory disease, sleep disorders, sex-specific risk factors, for example, PCOS, or your gestational diabetes. So these things are important. You have to ask about the diet, smoking, alcohol, because it's important for prevention aspect. Social history is important, social determinant of health. For example, I mean, it's not just like what's his income, what's his literacy, what sort of literacy he has, what's the housing condition. So these are all important things. And look at the family history, diabetes, hypertension, CKD, CVD, and then come to the exam. Well, at least the minimum things which you have to do is you have to check the blood pressure, check the BMI and the waist circumference, and look for evidence of any vascular disease or heart failure. That's the minimum thing you can do. And of course, the rest of the examination will be dictated by some of the findings which you have. And then do some tests. Again, the basic test would be a fasting blood sugar and lipid profile, and if also possible, HbA1c. And then, as it is necessary, or depending upon the availability, you can go for USCR, EGFR, FibroScan, ankle brachial index, ECG echo, calcium, coronary artery calcium scoring, or any functional tests of ischemia. Now, assessment of CV risk is important, which I mentioned before, and American Heart Association suggests using PREVENT score to assess a 10-year risk of your cardiovascular events. And the score doesn't only give for total cardiovascular events, but they also let you know, like, what is the chances of getting an atherosclerotic cardiovascular event or a heart failure. And the variables in the scoring system are the age, sex, total cholesterol, HDL, blood pressure, BMI, GFR, and so on. And of course, there are optional parameters as well. For example, HbA1c and USCR, and there are risk enhancers which could be taken into account in the calculation as well. And this I've already said, like chronic inflammatory conditions, sleep disorders, and so on. Now, this risk score is validated for age groups between 30 and 79, and not to be used as it happens scoring if the patient is already a known CVD or has an advanced subclinical CVD or has end-stage renal disease. Now, PREVENT score has not been validated in the Indian population, but still there are some societal guidelines which say that we can modify the risk by a factor of 1.5, and that would be applicable for the Asians. Well, hopefully that would be applicable for Indians as well, but again, these things have not been validated yet in the Indian population. This is how the scoring looks like, and that's the calculator which gives you this 10-year risk of CVD. And depending upon the risk, you could be high risk, intermediate, borderline, or low risk. And the risk enhancers becomes very useful when you're actually looking at the borderline risk, because they can help you up-classify the risk level. Now, this is important because when a patient with suspected or probable or definite CKM presents to you, well, he can present either to the GP or to the internist or the endocrinologist, nephrologist, or cardiologist. So it's all up to him, depending upon his presenting symptom or as he sees it, as he perceives it, to whom he would present. Now, the GPs or the internists, they usually see stage 1 and 2. Nephrologists would say see stage 2 and 3, and cardiologists would see predominantly stage 4. But they can see any stage as well. But the more important thing is, wherever you are, and if you see the patient, and if you think that he has some other diseases as well, then you best also consult or refer this patient to the other specialty as necessary. So that is important. And so coming to the management of CKM disease, well, the management, of course, it has some general measures. For example, lifestyle therapy. We have mentioned about diet, exercise, good sleep, giving up bad habits like smoking, reducing your alcohol. Mental health is also important. And the patient education. The patient needs to be made aware of the disease, and he should know his numbers. For example, what should be the target level of LDL in his case? what should be the level of glucose in his case, what's the blood pressure level in his case. So long he knows these numbers, he himself will be able to pay more attention to them. And there are different validated apps, available on smart phones and tablets, which can help to track the components of his of his lifestyle therapy. Because now the apps tell you how much you have exercised, how much calories you have burned, and that is very useful for yourself. If you will know that you have to lose weight. Now, what sort of also it will tell you about the about your glucose control. It will tell you about your blood pressure. A lot of things could be done through these apps nowadays, and I think we should ourselves first be aware of these apps and make ourselves familiar, and have to then extend that to the patients. And of course, we have ambulatory and home blood pressure monitoring. We have continuous glucose monitoring. These things would be helpful. And these patients who have multiple risk factors should be vaccinated against your influenza, pneumococcus, and Harvard zoster. Now, next comes to stage-dependent specific measures. This is the different stages, and I won't go through all of them. But as I've said, lifestyle modification and control of risk factors are vital. And then the rest, and when it comes to the pharmacotherapy, that depends on the stage of the disease and the comorbidities present. You have a lot of things to choose from this pharmacotherapy. But what you're going to choose, this is something you just, you use your brain, and I think you can get the answer. A patient comes with in stage 1 with the basic, you try diet, exercise and all, it doesn't work, then you think about anti-obesity medications. And you have anti-obesity medications now, especially if this patient has obesity along with some other risk factors, then of course you would need the patient's weight needs to come down. Now, if the patient has hypertriglyceridemia, of course we know that if the primary objective would be to reduce, in patients who are at a high risk, to reduce the LDL. So you increase the statin, and once the LDL level is achieved, and if you still have an elevated triglyceride, then of course you may consider in specific cases eicosapentaenoic acid or maybe fibrates, depending on the triglyceride levels. And then say hypertension. Of course, in hypertension, the main objective would be to treat the level of blood pressure, bring it to the target level. But again, if this patient has proteinuria, say CKD with proteinuria, then you can think about at least giving them herbs or A's. So that's how you do it. And say the patient comes in with a CKD, and the patient has CKD with proteinuria, you think about herbs or A's. If the patient has, or rather with SGLT2 inhibitors, if there is no proteinuria, just CKD, and if the patient has a diabetic nephropathy, then you think about phenylalanine, or even now we know from the flow study of the GLP-1 agonist. And similarly, if the patient has subclinical coronary artery disease, you have done a CT scan, it's a lot of calcium, you give this patient statin, and if the calcium level is very high, say 300 or more, you also add in aspirin. So these are the things you have to do, and the same is true for patients who have LV dysfunction, maybe asymptomatic LV dysfunction, not very uncommon. Patient doesn't have any symptom of heart failure, but the ejection fraction is 40, say, or 45, or even 35. What are you going to do? So we have evidence that in such patients, giving beta blockers and ACE or herbs are helpful. So that's what we can do in such patients. And of course, patients who are very obese and has cardiovascular disease refractory to other medications, you also have bariatric surgery available. Now coming to this stage 4 disease, which is the advanced stage, where the patient has CKD very high, end-stage CKD or CVD, very clinical CVD. Here, of course, the treatment is secondary prevention, you all know. Now, although implementation of care in the Indian setting may vary depending on whether it's provided in the primary, secondary, or tertiary care, or in the public or private hospitals, availability of an Indian practice recommendation may provide a framework to guide physicians to approach patients with CKM syndrome within the limitations of their practice environment, and understand when to refer these patients to tertiary care or to the other specialties. And therefore, I think it's very important that we have an Indian-specific guideline on CKM. So to summarize, South Asians are disproportionately affected by cardiometabolic and kidney diseases, often at the lower body weight and younger age, a higher atherosclerotic burden, high prevalence of insulin resistance, metabolic syndrome, hypertriglyceridemia, hypertension, diabetes are characteristic of the South Asian population. Early detection, integrated preventive approach, and targeted interventions are crucial to prevent disease progression. While a common practice recommendation is appreciated, a country-specific approach is necessary. All adults 20 years or more and those with risk factors for CKM should be screened, and although not validated in the population, prevalence score modified by a factor of 1.5 may be used to assess the CV risk till we have a risk factor of our own, till we have a risk calculator of our own. And although the patient may first present very specialty, interdepartmental cross-referrals are usually necessary when the disease has advanced to stage 2 or beyond. So availability of country-specific guidelines are likely to help in implementation of care in the Indian setting. Thank you.
Thank you very much, Subra. I have a couple of questions. Do anybody have a question from the floor before I? Okay, Obi, you go first.
So thank you, Dr. Banerjee, for enlightening us with a very current topic of importance and where we all should merge upon to share our views. So a little more CKM, we have 3 hospitals together. We were trying to look into the CKM, and I was trying to spot out according to stage. So what I observed in my OPD clinics, I have seen obese, pre-diabetic, proteinuria. So our focus from a nephrology point of view 5 years back would have been, it is obesity-induced secondary FSGS. So that way we would proceed without screening the cardiac aspect of it, which might be NT-proBNP more than 700, or looking at other criterias of that the pre-diabetic state, that how I could intervene that, particularly after availability of SGLT2Is specific, which have definitely costly, who have ability to pay, they can have that advantage, and rest of the people with exercise and all. The obesity reduction to be the crux of the point management as a primordial prevention, as you were sharing. Most of the time I'm not finding very raised creatinine. It is 1.2, 1.3. The screening of diabetic status is 6 or 5.8 or 6.2. So not an over diabetic, not requiring diet, not requiring drugs, but having proteinuria and obesity. This is the cohort that is reaching nephrologist, I feel. Thank you.
Thank you. Subra, I've got 2 questions. Very short questions. You can give yes or no answers. So number 1.
Proteinuria is very, ACR is 300, 400, but it's not that. Yes.
More than
and albumin is not less than 2.5, so then so I can call them nephrotic. Preserved albumin level, albumin creatinine ratio raised, not the PCR raised.
Thank you. My question is, in primary care, 2 things, yes or no answer. Do you think we should include creatinine and urine albumin ratio as a screening test? And number 2, do you think the primary care physician, whoever it is, I don't know, in private sector or in public sector, can they start the statin and the ramipril?
Yeah. Well, I think it depends which country you're looking at. I mean, it's.
I'm talking about India.
Oh, India, right. So in primary care physician, when we say primary care physicians, it's also like, is it in the cities or in the more tertiary or peripheral centers? Let's talk about cities. That's probably or more metropolis, or maybe more tier 2. Yeah. In that case, probably what you can say, I would say creatine, yes, you can do that. That's easily available, but ECR may not. So in that case, at least what we can do, we can catch those who are probably a bit more advanced and do just an urine examination for protein.
You mean dipstick?
Dipstick again is very expensive here. So you have to send it to the lab.
Okay.
And that is done everywhere. So at least we can look for protein, which would not be the ideal, but then of course that means a macroalbumin level where we can catch them. But I doubt it whether even if it's in the cities, large cities, fine, we can do ESR. But beyond the cities, I doubt whether we can actually implement that. See, if you see there, I have actually put it in my brackets. That's why USR. Sorry.
Dr. Banerjee,
Yes.
ACR, you are mentioning,
Yes.
ACR is now widely available. Yes.
How expensive?
How expensive?
It's point of care.
Point of care.
Will it be 10 rupees or 100 rupees or 1000 rupees?
How reliable?
300.
300 is not bad. 300 I think is affordable. But so it is just as a point of care device, we can do it straight away and get the results?
Yes, yes. Yes, possible. Possible.
And it's reliable.
Point of care possible.
Okay, so 300 rupees for an ACR. How much does a creatinine cost, Subro?
100.
Don't ask me what it costs.
100.
100. Okay, so creatinine we can do, albumin creatinine we should do 400 rupees. And what about the simvastatin and liraglutide in primary care, in a city?
Simva is not available.
Simva not available.
Yeah.
But I think atorvastatin is cheap.
Available.
And it's not that expensive, probably some 5 rupees. 10 milligram would cost you some 5 rupees or so.
For a month?
No, for a month is 150.
150. And what about Ramipril for a month?
Ramipril again is
Cheap.
It's cheap, but you have another pill which will be captopril. It's not available.
No, captopril is not available. Ramipril is available.
Okay, is that Ramipril?
Ramistor.
Yeah, but five.
I don't have. Not very costly. Ramipril is not. Very
So
costly.
150 again.
Am I wrong? No, not very costly. Yes.
And the last question.
Aspirin.
Would you, no, I would have asked aspirin, but let me ask you something different. Metformin for weight loss.
Yeah.
So in England, the problem is metformin according to BNF, if you want to use it for weight loss, it has to be by an endocrinologist, which is ridiculous. So would you use metformin in primary care in a metropolitan city for weight loss?
Well, I think it depends also because we have to make them aware that they must check the creatinine first. We do not know the creatinine level.
We are already checking the creatinine.
Yeah. So in that case, I don't see there is a problem. We can give them metformin. But then I
To
would give it
GP
to
level,
the.
that education must go. That.
This is the
GP.
point. To treat all of these patients in primary care, we need to educate people. And I think the education should start in the medical school. Because when our students graduate, they don't know anything about multiple long-term conditions. But that's the truth. Nobody's going to probably see any kidney disease anymore. They're going to see kidney disease with a heart disease, with diabetes, with obesity. And I think it's everybody's responsibility to treat them. Every encounter for the patient should matter. And remember, in India, there's a huge inequality. So somebody might see Shubro, but very few people will. Others might see you, again, very few people will. But a lot of people might encounter a general physician somewhere out in the village, right?
And Niladrida and Shantashi.
Well, nobody will see them either. So I think that's where we need to talk about the education of the next generation of doctors who are going to be managing this multiple long-term condition and not a single monogenic disorder that often. Sorry, Nick.
Don't you think this education should start at the school level?
That's
college
it.
level, not medical college. It's the general population that
no,
has
I
to
think-
talk about
Anti-obesity campaign should be there for
Absolutely.
general population.
Absolutely.
Anti-obesity.
Yeah, that's true.
Yes.
And it starts with the school because we know like this sugar is a taste, it's an acquired taste, salt is an acquired taste. So if from that age we can actually stop them developing this sort of taste, then probably later in life when they are not going to crave for salts and sugar. And I think
Babies have a sweet tooth like anything.
that's a problem, yes. And also I think Devashish, which is very important for us also, we should start thinking CK or CRM. Whenever we see a patient, it's not just obesity, it's not just hypertension. We should start thinking CK.
Yes.
2 years.
So with that, we're going to move on to the next session because otherwise we'll miss lunch. And the next session, Subrikan, will be Nick, right? Who is chairing the session?
Chanto.
Shanto, and Ilatri.
Okay.
Yes.
There you go. You have to start soon. So that is, we'll make the rush. We can start.
Yes, yes.
We have already had hepatorenal, we have had cardiovascular metabolic kidney disease, and now we will have cardiorenal AKI. We have already had a wonderful lecture from Dr. Emir earlier. So again.
Well, thank you very much. So yes, I suppose I've self-diagnosed myself with CKM1. I know that we're meant to breakfast like a king. We're meant to have lunch like a prince, and then you're supposed to have dinner like a pauper. But I know that I've definitely had dinner like a minor deity, and I had breakfast like a king this morning. So I think what we're trying to do is make it so that there's so little lunchtime that you have to have lunch like a pauper, or no lunch at all for today. There's my presentation. Right, well thank you very much again. So this is relaying to another part of my life as a kidney doctor, and acute kidney injury, and very specifically cardiorenal acute kidney injury. And so if we have the next slide please. Oh, pointer, okay. All right. So yes, we were very privileged driving around SSKM today, and we saw the trauma centre, and this here is St George's Hospital, and just above is our trauma centre and the helicopter pad. Down here is the emergency department where people come in by ambulance or by foot, and then over here is the cardiac and neurology building, so just beyond the emergency department. And over here is where we run the acute kidney injury clinic. And then over out there is where the GP practice, which was the even better building and the beautiful offices that you saw that Isaac was showing me. We'll just start off with another case. This is a 53-year-old Afro-Caribbean female with hypertension. She is on irbesartan, 450 milligrams, furosemide 80 milligrams, doxycycline 60 milligrams, and amiloride 20 milligrams. So she's got pretty resistant hypertension, and she's become increasingly breathless with leg swelling for the last 3 months, orthopnea, paroxysmal nocturnal dyspnea, so she's lying on 3-4 pillows at night. Her blood pressure is 191 over 111. Her pulse is 87 beats a minute and regular. Her oxygen saturations are 95%, and she's got edema all the way up to her waist. And I always kind of use this kind of broad idea that if you've got edema to your ankles, you've got probably about 2 kilos of extra weight. If you've got edema to your knees, then you've probably got 5 or 6 kilos. You've got edema all the way up to your hips, it's probably about 8 kilos. And then if it's going above your waist and you're basically anasarchic, then you've got about 12 extra kilos of fluid. So she's definitely got at least 8 to 10 kilos of extra fluid. And her ECG, sinus rhythm, echo, ejection fraction, 35%, which has decreased from 45%. And sodium's 141, creatinine's 215, hemoglobin 123, inflammatory markers not too bad, but the BNP is raised up 1167, and the urinalysis is negative. So she's admitted to hospital. What's the next best step in management? And I suppose, should we just have a show of hands? Oral furosemide, 120 milligrams twice a day, up from 80. Spironolactone, 25 milligrams once a day. Intravenous furosemide, we've got 4 votes. There's 5 votes, or an increasing number of votes. Empagliflozin, 10 milligrams once a day, and a few extra votes. And intravenous acetazolamide, 500 milligrams once a day. Okay, so I'd say a preponderance of votes more for the intravenous furosemide and maybe a little bit of SGLT2 inhibition, which is reassuring. So she has gone on furosemide, 200 milligrams intravenous infusion over 24 hours. We've stopped the irbesartan and started salcubitril valsartan. And we have stopped amiloride and started spironolactone, 50 milligrams, and not yet had the dapagliflozin, but her kidney function has gotten worse. From 215, it's gone up to 270. So what's the next step? Should we say continue with the same treatment? Check for urinary tract infections and sepsis? Cool. One definite vote from someone who's slightly related to the talk. Stop the intravenous furosemide. That's a relief. She's already overloaded and is around 8 kilos overloaded. Reduce the dose of intravenous furosemide. Stop the sacubitril valsartan. Possibly, in order to preserve the blood. Well, is she hypotensive then? That's an interesting question. Stop the spironolactone and check for urinary tract infection and sepsis. Okay, so some nuanced responses there, I think. So her weight has gone from 100 kilos to 92 kilos. So we've managed to get 8 kilos of weight loss off with IV furosemide. Blood pressure has improved from 191 to over 111 to 132 over 84. We've got a good urine output, and she's discharged on day 7 with furosemide and SGLT2 inhibitor. We've managed to get that in, and the ejection fraction has come back up from 35% to 47% 1 year later, and the creatinine at 1 year has stabilised. There we go, stabilised, which is excellent outcome. So the incidence of acute kidney injury in heart failure, and here we have 2023 paper and our own data from St George's shows an increase in an increase in mortality with increasing severity of AKI, and but the predominance of AKI stage 1 amongst our patients with heart failure. And broadly speaking, we are saying that worse AKI equals associated with heart failure equals worse mortality. But having an acute kidney injury, I suppose, is almost a physiological inevitability, we might say, in these circumstances, because what we have is, in the setting of fluid retention, or I suppose if we look at the respective causes of heart failure, we have hypertension, ischemia, dysrhythmia, infections, PEs, AKI, medication non-adherence. How often we have patients who are, don't like going and taking furosemide, don't realise that furosemide in America is called Lasix because it lasts for 6 hours. So if they start taking their water tablets at 10 p.m. when they, or just before they go to bed, they'll be peeing all night, and so they don't like that, and they stop them. And then they end up with acute heart failure presenting much later, or a couple of weeks down the line. Or causes of acute kidney injury, sepsis, urinary tract infection, hypovolemia, drugs and interstitial nephritis, all of which can contribute to worsening urine output in the setting of their normal medications, and their impact on presentation with acute heart failure down the line. And of course, it's a vicious cycle. We end up with, one of these is here, increased fluid retention, increased the preload, increased activation of the renal angiotensin-aldosterone syndrome, increased afterload, and then with worsening heart failure, decreased renal hypoperfusion, increased renal congestion, and just potentiating the negative feedback loop. So we have to break the cycle. We have to offload them. And part of that, in the first, these are the European Society of Cardiology guidelines. The first is to use diuretics to offload, and if we use diuretics to offload, then immediately we'll need to the potentiated circumstances for acute kidney injury. And the impact of acute kidney injury with and without decongestion on mortality. So there was no difference in mortality between acute kidney injury and no acute kidney injury if there was no congestion at discharge. So we're happy. I think that probably the main message is don't be afraid of an acute kidney injury in the second heart failure. And here we are using diuretics and using urinary sodium measured to demonstrate that the IV furosemide is having the desired effect. So a urinary sodium of greater than 70 millimoles leads to us continuing our IV furosemide. If the urinary sodium is not quite 70, then we will want to optimize the dose in order to do this. Broadly speaking, I'm thinking that if we have a worsening kidney function to start with, a creatinine of say 200 micromoles per litre, I will often be starting a much higher dose of furosemide in order to get the same effect that I would with no evidence of pre-existing kidney damage. So first of all, we're trying to offload with intravenous furosemide, but we're conscious that if we're not having the desired effect, there may be other comorbidities associated with this that is making it more difficult for us to offload, whether or not there may be sepsis, if there's fevers, evidence of hypotension, then we may need to treat other aspects that may be making the comorbid situation even worse. And if we have acute kidney injury that is prolonged, then with prolonged renal hypoperfusion, then there may be acute tubular damage, and that may make patients more resistant to intravenous furosemide treatment. But nevertheless, we just still have to keep on going in the setting of worsening kidney function. And I suppose the main message here is that we are trying to individualize our treatment for acute heart failure and associated acute kidney injury according to the clinical context by monitoring weight, blood pressure, pulse, edema, and their creatinine, and looking for other causes of comorbidity that may be making the current acute situation worse. And there have been several studies looking in acute heart failure, looking at acute kidney injury in heart failure. So when to worry? With acute kidney injury, stage 1 with decongestion and no urinary tract infection, sepsis, and no raised CRP, we're happy. With when we notice that with AKI and we are not offloading effectively with intravenous diuresis, we've got concomitant sepsis, a raised CRP particularly over 100, and AKI 2 or 3, worsening AKI with decongestion. These are all situations where we're a little bit more worried, but we need to persist. And AKI with significant worry is AKI 2 to 3, which is refractory to IV furosemide and concomitant sepsis. And there we need to be thinking about the appropriateness of in intensive care and offloading in that setting, and potentially dental kidney replacement therapy. So over the course of an inpatient stay, we're looking to offload patients with intravenous diuretics, to use vasodilators, inotropes where appropriate, and vasopressors to try and improve the cardiovascular situation. We're trying to then switch them over in the intermediate phase to their guideline-directed medical therapy, to the four-pillared care, get them onto oral diuretics, and then just before discharge, we are looking to have them on goal-directed medical therapy. You will be hearing a little bit more, I hope, from our colleagues tomorrow, from Mimi Chen and from Mark Patchazan, about devices and about the long-term goals that we're looking for, having navigated through the acute situation. So again, I suppose all the elements of the guideline-directed medical therapy can contribute to the picture of acute kidney injury, and yet we must, to a degree, tolerate that. But we can see that over the course of a year, or 36 months of treatment, having offloaded acutely, having offloaded acutely, we can actually stabilise decline in kidney function with optimised guideline-directed medical therapy. And broadly speaking, it is GDMT is safe in heart failure, in acute heart failure. So the key messages before we race off to lunch is that worsening renal failure or acute kidney injury is common in acute heart failure. A mild acute kidney injury, stage 1 and 2, and decongestion is good, and the prognosis in that setting is good. A severe acute kidney injury with no decongestion, refractory to intravenous furosemide, is bad. We need to look for other causes contributing to the acute kidney injury, treat those, consider escalation and the appropriateness of escalation. We can't escape the fact that we have a number of patients in these kind of situations who are increasingly frail, increasingly comorbid, and for whom a palliative approach may be more appropriate. But we should aim, in general, to start guideline-directed medical therapy prior to discharge, because it is safe to do so and will contribute in a positive way to their long-term outcome. Yes, this was just a picture of Old St George's, 1730s, and how it's changed. In fact, we moved from Hyde Park down to Tooting, to where all of our patients were. I realise there's a lot of detail that we skimmed over in the interest of getting to lunch like a prince. Do you have some questions?
Yes, thank you, Dr. Inge, for your talks. I just wanted to ask, how do you manage a patient with hypernatremia and volume? So we get these patients a lot. Any intracellular hemorrhage and that sort of thing, which causes a central DI sort of picture.
So hyponatremia or hypernatremia. So, well, I think, often we're finding that these patients have an excessive salt intake and fluid restriction, salt restriction, and diuretic use is important. We find more problems actually with hyponatremia. But are you talking about in the sense?
ICU patients, what happens is that they are volume overloaded.
Yes.
And they get normal saline from somewhere.
Yes.
And they end up with heart failure, with hypernatremia. Often these patients have a ICH or an intracerebral problems. So we get a picture where the patient is bloated, hypernatremic, and going into heart failure. It becomes a very difficult situation. And it becomes quite difficult to control the hypernatremia due to the central DI or whatever that is going, that part of that is going.
It is in ever more complex. I was thinking of the opposite, where we have hyponatremic patients who we're trying to start. But I think yes, we're starting off with a fluid restriction, trying to in a tempered way, attempting to diurese, but recognising that excessive electrolyte changes will have a negative effect on cerebral outcome. I mean, generally speaking, this is associated with a very poor outcome, this kind of clinical situation. And I suppose the most important thing is to counsel the family about the likelihood of us not succeeding in that kind of situation. I've only seen it relatively rarely, but yeah, very much.
Join to that answer probably.
What about the other diuretics that often we add, like hydrochlorothiazide or glaptans in this sort of resistant heart failure?
Yes, so I mean we are often using co-using multiple different diuretics as in order to so it's not just furosemide, it's also spironolactone, dapagliflozin, and metolazone, all in combination in order to get the optimal outcome, because offloading is the most important element in this setting in order to try and navigate them safely out of hospital. Absolutely. But yeah.
So furosemide in infusion or intermittent dose?
Well, that's also a wonderful question. I generally go on the clinical situation. I think that all too often, as mostly a ward doctor rather than an intensive care doctor, it very much depends on whether or not we've got a urinary catheter in. Or if we've got a urinary catheter in, then I'm happy enough to give lots and lots of bolus doses of furosemide in order to get a decent concentration over the glomerular basement membrane. Okay, and so I'm often going for AT, IV, BD in order to achieve that. But if we've got a catheter inside you, I will often go for 240 milligrams IV over the course of 24 hours, a continuous infusion. I find that the bolus doses get some more effective diuresis. If I know that we're going to be in here for a week or two, then and we need to be very, very careful because the blood pressure is right on the cusp of falling. We often have quite hypotensive patients in this situation. We have maybe a blood pressure of 105, systolic or 90, and then we often go for a furosemide infusion, graduate for a furosemide infusion. It's very delicate, things could go either way.
Last question, Jonathan.
When do you consider ultrafiltration and the other measures?
Yes, and peritoneal dialysis in certain situations can help, but I've often lost patients in that clinical situation because of the many risks of getting concomitant infection in that setting too. So, yeah.
Thank you very much. We'll break off for lunch. Do we know where the lunch is?
We are not breaking for lunch. We have a transplant expert meet. Cardiac transplant surgeon is Boshachi बोलते.
All right. Okay. So
Yes.
we're not breaking
So
for
there
lunch.
is
So
a
who is introducing?
session.
Yeah. Okay.
There
correct.
is a session. So good afternoon. Please bear with us for few more minutes. We will be in a transplant expert cross talk. I would ask the people. So in SSK, we usually do 3 types of transplantation. Renal transplantation, liver transplantation and heart transplantation, all 3. So it is very important to note that we often, when I worked here 2 years back, I received referrals from both renal as well as from both liver as well as cardiac side after transplantation due to AKI. So I was looking at AKI at that point of time, post-transplant, and now when I am practicing, I am even seeing cardiac transplants progressing to CKD or liver transplants progressing to CKD. So I felt that we should discuss it with the liver and cardiac surgeons, that and discuss what are the pre-transplant, peri-operative and post-transplant issues, so that together we may convey some good message to our students. So that's why the thing was brought up. We had called liver surgeon who has become busy in liver surgery today. So Dr. Ramdeep Rai missed us. Dr. Moin was chairing the session. He will chair distantly. So now in absence of Ramdeep Rai, Dr. Moin will, he is a hepatologist. He is in IPGMER. He will join us as transplant expert from liver side in absence of Dr. Ramdeep Rai, and for cardiovascular, as cardiovascular surgeon, Dr. Debashish Das will join us. For good comments of managing the patients, Dr. Pratik Das is available, who is well known to all of us as nephrologist and doesn't need new introduction. And I am very proud that he belongs to this institute. And I would call up Dr. Pratik Das, Dr. Debashish Das, and one of my junior colleague, Dr. Dipankar Sarkar, who is no more in government service, but is very, very close, near and dear to me. And I think when I joined as teacher, Dipankar was almost joined as student. And we together grew, sharing many things of learning. I was learning as a new teacher, and Dipankar was learning as a nephrologic trainee. Now he is quite mature and treating all cases, and he's an excellent person also. And for introducing to this ISN TTS, Dipankar worked hard. And I'm sorry that I missed the opportunity to work with him. Please, Dipankar, come and join. Hand mic to Didi.
Madam.
And next slide, please. So, predicting the post-renal composite renal outcome, another chair for Debashish.
I think I'll just run through the slides.
Or Dipankar and Pratik, if you want to move on the first row, that would be convenient. So, predicting the post-renal composite heart outcome published in KIR was a trigger again to add this talk to this meeting. So, why the AKI? What is the pre-transplant legacy versus post-transplant? Or the perioperative event, the recipient risk factors, drugs, how to find out reversibility. Next slide, please. Similarly, post-liver acute kidney injury, I felt that pre-transplant comorbidities, doctor-patient factors, donor-recipient factors, intraoperative factors, and post-transplant drug all are playing important role. To remain conscious and aware when we are treating, we have asked for case scenarios from liver surgeons and cardiac surgeons, which they have shared.
Comforting to be surrounded by physicians who take care of the organ we fear most, so that it shouldn't give up on us is kidney. And we are usually obsessed with urine output and kidney function tests in any cardiac surgery scenario. Transplant being one of the foremost of them. I have just chosen two one very rare situation and one a relatively common situation. We'll quickly run through it. If you could go to the slideshow, I'll go to the next slide. Or you can just run it like a video, that's also. Scenarios where we struggle with the kidney post heart transplant, just move up. Just put this PPT and I can move it. So this was a 52-year-old gentleman, known case of dilated cardiomyopathy with the usual burden of comorbidities of AICD implant in January 2020, ejection fraction of 15 to 20%, significant regurgitation in tricuspid and mitral, The right heart study, usual workup for transplant was done, enlisted in 21, and 3 months later we were lucky to get a heart. Normal pre-op kidney functions. This patient, so all these transplant patients who are listed, sometimes we don't have the luxury of stopping sacubitril, valsartan and other medication that we would stop. Underwent the uneventful transplant in December 2021. Just pull it up. So this is the AICD implant. This is a post-transplant heart, relatively uneventful. We use a continuous cardiac output monitor. Cardiac output post-op was absolutely fine most of the during the entire night of the transplant. Go down further. So we shifted with our usual inotrope choice is a bit of noradrenaline of around 0.05 mics and Milinon at around 10 p.m. Stable hemodynamics, cardiac output monitor was okay. Our SVR measurement is basically the catheter that we use. We have to intermittently use, we don't have a real-time continuous SVR on the monitor. So we would check it every 2 hours or so, and it was SVRI was around 1800 to 1900, so on the lower side but still within the normal range. We planned for an early extubation next morning. In the morning when the patient woke up and we were about to be in ventilation, the patient developed sudden unexplained hypertension requiring increase of NORAD, and because the change was so dramatic, for the want of a better thing to do, we just shifted the patient from the unit to the OR just to have the luxury of necessitating ECMO and instituting it if it was needed. So move up. So we shifted and because we were not, just to try to figure out if there is anything mechanical which is causing this, we opened the chest and then we started assembling our ECMO setup. I realized that the time was of an essence here, so we put the patient on a supportive bypass, just conventional cardiopulmonary bypass. The SVR again when we measured in that time, so I must admit that during the time when we measured the last SVR was around 4 a.m. which was on the lower normal side, but by the time we shifted to OR, the SVR was really low. We increased the vasopressors, put the patient on bypass. We of course did a transesophageal echo which showed good biventricular allograft function. We kept the patient on CPB for 45 minutes. For the want of increasing the SVR, this is our last choice. We would use methylene blue only in dire circumstances, but we started a bolus of 2 mg per kg and the SVR dramatically improved. We had better hemodynamics. We always had good urine output all throughout. We left the chest open just to be sure that in case we need to institute ECMO, we would do it bedside, and we shifted the patient to the unit back again. Go further. And I think there is one slide before that. So we extubated the patient the next day, hemodynamically stable, pressures gradually were weaned off, the SVR held on, standard immunosuppression. We started tacrolimus a little bit late because he did have minor neurocognitive issues. CT brain was done, which was normal. He developed an AKI, non-oliguric AKI. The creatinine gradually from 1.2 rose to 3.9 in this particular manner. And then after consulting our nephrology team, we instituted SLED he needed it for 72 hours, gradually recovered, was never significantly oliguric at any point of time. He did have, because of this, his stay was a little bit prolonged, and he was discharged on 21st post-op day. Kidney recovered fine, the ultrasound kidney was always normal, and it has been 4 years after his transplant, and he's completely okay. He plays badminton, he's an engineer in the electrical board, works as a chief engineer and works fine. One dramatic thing which we noticed after using methylene blue, we have used it very rarely, that the patient gets discolored significantly. So I had a tough, although the patient was doing fine, I had a tough time explaining to the relatives as to why is he looking like this. But he recovered. This is a very rare situation, but I think it is an effect of pressures which we could not control to an extent because we wanted the SVR to ride. It probably had an effect on other organs. His transaminases, his liver function surprisingly were never high, but the kidney did take a hit, which was our choice for renal replacement therapy immediate post-transplant. At that point of time, we did not have the CRRT machine, but then between the two institutions now we do have, and our first choice now in a post-transplant scenario, if we need to institute renal replacement therapy, we would use CRRT rather than SLED, especially in acute situations within sort of first 48 hours of transplant. So this was one very rare case that we encountered.
Before you go to the second case,
yes,
I would ask a question to Dr. Dash. that Pratik, do you think there was one point that gave a trigger that he might have bad renal outcome in the pre-transplant history? That is, he required ARNI in the pre-transplant. Usually those people who require in ARNI in the pre-transplant, their prediction goes that they may go worse in. So what do you think that any pre-transplant care would have ensured better, ensure something to avoid this acute kidney injury?
No, basically
Is it
this
possible?
patient not only.
We can hear you.
So this is a patient who had an ejection fraction of only 15%, I think. So as you.
So you take a loudspeaker, change color.
The ICD was there in it.
No, ma'am. So for 1 year, the ICD was implanted. It had given a shock once in 1 year. Ejection fraction did not improve, and then we enlisted.
So the two factors. One, as usual, this patient was at his renal risk because of this low cardiac output, not because of the drugs treating it, but reason. So there is every possibility he will develop AKI in the post-operative period. And this transplantation, you probably received the organ as the scenario in our country in an emergency basis. So patient probably was not optimized at the time of the surgery. Still he went, everything went good until first 12 hours or such. After that, there is a hypotension episode. That basically precipitated this AKI.
Yes.
And that is recovered nicely as because probably patient was non-oliguria. This may be the one reason the patient recovered gradually.
So, at no point of time we had oliguria, and that was a comforting
But
thing.
the things, the story doesn't end here because he has a recovered function with the creatinine of now 1.2. Probably he has entered in a phase of AKD from AKI. His recovery was less than optimal, and if you follow these patients for the next down the line 5 years, he might or probably will develop an CKD in the long run.
Because he's also a diabetic in the background, so I think that adds on to another morbidity.
So for him, is a close monitoring is required not only for a creatinine with the eGFR and the urine albumin creatinine ratio. These things needs to be followed up, and the treatment or additional drugs if it is needed in the post-operative period and the renal protection that should be initiated.
So after this case, what we did, the change that we did in our this thing, that when we do an NBT for enlisting a patient, we would involve our cardiologist, cardiac surgeon, anesthetist, critical care physician, and now we don't start the meeting till the nephrologist is there. You know? So that is the change.
So
Can I say something? I mean, just to refute what Urpita was suggesting, that, sorry, I'm loud enough. Just to say that we do encounter these patients in our kidney heart failure clinic, which we run every Thursday afternoon. And to our surprise, sometimes with the Entresto at a maximum dose of 9703 for good enough times, for I think 6 months. I can remember very clearly, there's a gentleman who was 39, came in with a ejection fraction of around 15%. And we were all very scared. He's only 39, right? Recently, his wife has a kid as well. We gave him. He was in the lift study, so he was on Lokelma and everything, and his ejection fraction actually has improved. He does not require a heart transplant. So
that's true.
Sorry about your your loss here, but you don't need always a heart transplant, provided you treat them very well. And he's not the only case. We have seen quite a few patients where if you treat the heart failure well, you probably buy enough years for them to live without a heart transplant. So I would not stop the sacubital valsartan, whatever you say.
So actually the prediction of sacubital valsartan use in this situation, that has the background of very poor EF patients.
Yes. So these patients have had their medical management. They're enlisted now. And once they are enlisted, if we know that these patients live in vicinity of the hospital, and by the time the first brain death declaration notice comes to us and the organ is donated, sometimes we get 72 hours because the family. So we immediately call them to the hospital, stop the sacubital valsartan, just to not have these situations of acute vasoplegia. But then those situations are very rare. Most often we would get the call in the middle of the night. By next morning we have to retrieve the organ and transplant. So that is why sometimes it is not possible.
These patients, the heart transplant is a probability, it is a chance. they should not be denied of getting any of the anti-heart failure drugs which has a proven scientific benefit.
So you can move.
Just like you don't stop clopidogrel, you stop clopidogrel before CABG.
No, we don't.
You just manage bleeding in other ways. It's like that.
Thanks. So the second is more common scenario. This patient did not require a renal replacement therapy, although did get us worried. This is a 24-year-old male, classic DCM with ejection fraction of 15%, enlisted for transplant after a right heart cath, was on triple. So these patients' pre-op management, again in our part of the world, is a bit disjointed because they will be managed by adult cardiologists. Sometimes they would come to us. We would take a nephro consult based on the creatinine. We would take sort of other critical care opinions for after enlistment. But it is not in a very cohesive manner, and that is why we are not always in control of the medications that the patients are on. So he was on triple diuretics, furosemide, spironolactone, metolazone, repeated, and in addition to other heart failure medications, repeated admissions with heart failure. Pre-op creatinine was around 1.5 to 1.7 with a relatively high blood urea as well. And with that, suddenly, because he was a young patient, we got an organ, and he was an AB positive recipient. So it was rare to get that quickly, and so we went ahead with the transplant after a discussion with a pre-op creatinine of 1.5, and it peaked to 2.6, always with a good urine output, no cardiac issues in the post-op at all, and we managed them conservatively. His creatinine trended down to normal by POD4. We delayed the tacrolimus to day 7 in this case, and then managed it. However, I just wanted to highlight this, that in these situations what happens is the balance between the heart failure medications, diuretics, the effect on kidneys. We are probably not the best person to address this, and somehow that multidisciplinary interface is still, in spite of, we have made a long journey, but there is still a long way to go where we can collaborate better to have these patients better optimized, so that peak of 2.6, if we collaborated better, probably would have been avoided, and that is the reason and this is a fairly common scenario. The methylene scenario, I hope I never face it again, but this probably will face it again. So that was the reason.
So I will direct the question to the Pankaj, that you are seeing CKD, might be a CKD patient, creatinine, pre-op patient's creatinine is 1.5 to 1.7. I am not stamping CKD, but it might be AKI due to compromised EF. So how you are going to add your valuable advice in the MDT meeting so that post-transplant hazards are less?
Ma'am, this is a patient with chronic cardiorenal syndrome, so that is the reason why the creatinine is rising. There is nothing intrinsically wrong with his kidneys per se. The reason why this creatinine rose is that we are giving diuretics, and the situation arises when the patient gets dehydrated a bit with the diuretics, and we are afraid to decrease the diuretics because of fear of ejection fraction of 50. The trick will be to maintain the hydration but not give too much, also give enough fluid but continue the diuretics also to maintain a proper balance. I would like to ask Dr. Banerjee, how will you manage this?
No, this is not a scenario we uncommonly face. Remember, the goal of treatment before the patient gets to you is to keep them out of hospital, right? So that's why he's on metolazone and furosemide. Spironolactone obviously is a part of the GDMT. So I think this patient needed that to keep him out of hospital. Otherwise, probably you would have never got a transplant.
Absolutely.
Right? So you have to manage these cases when they come to you. What can you do? Pratik wants to say something.
No, this is one kind of the trade. You learn the trade-off hypothesis. We have just to keep the patient alive and out of hospital. Then only you can do the further treatment. So you can accept this amount of rise in creatinine and
Actually, the post-operative period, because we have invasive pulmonary artery catheter, we have a cardiac output monitor, we can measure the PV RSVR on a regular basis. So the fluid balance post-operatively at least is taken care of. So with that amount of renal derangement, we can manage these patients with our nephrology help easily without getting on to an RRT stage. That's what.
And the difference between the two patients you presented, probably this patient doesn't have any intrinsic renal problem.
Yes.
And the other patient, probably, although the creatinine was normal, might have a diabetic kidney disease underlying, and that precipitated.
And he was also 54 years old, so it's on the higher side of age. Yes. Thank you. Thank you for your attention, and yes, please.
Did he have a genetic?
No, we can go further than GIMER case. Thank you for coming. Devashish was in Heartland meeting in Jaipur. Devashish took a flight in the morning, directly came to us.
So the Indian
I'm sure
Society
we
of
missed
Heart and
it.
Transplant had a meeting in Jaipur over the weekend, and we discussed fairly similar scenarios, but there was not a single nephrologist present in the meeting, and that is the beauty of attending these meetings, because we get far better inputs when we collaborate in a multidisciplinary manner. Thank you. We will go on to the liver case.
So much.
Where is the lunch, Obita?
আপনি সবার আগে এসেছে জানছি স্যার প্যাকেট লাঞ্চ
Hospital on 14th of this month. Please attend. It will be in the Hyatt. Tuesday we'll take. So please attend. Because it's a lifetime experience. Probably will not come again in India and Israel. And secondly, there is an electrogenetic program with international speaker on 25th of October. The juniors are required to register for this.
14
আর 25 very important.
দুটো প্রোগ্রাম স্ট্যানলি জর্ডান কিন্তু সত্যি আর দেখবে না তো রজত ইজ দেয়ার না হি উইল বি দ্য মোস্ট অ্যাপ্রোপ্রিয়েট পারসন রজত ইজ আওয়ার critical care person, and once he moved into trauma, the number of brain death declaration increased. So he's the best person to chair the deceased donor pool expansion session.
Expanding deceased donor pool. এটা তো প্রথমে
With project.
Right, I think we should get started. Thank you everybody coming back again. So everybody's ready. Can you all please take a seat? I hope you had a good lunch, all of you. You had one time. So we will start off with Abbas, are you sharing your slides? Have you been successfully sharing your slides? Can you
পূজার প্রেজেন্টেশনটা তো বের করে কেটে দিতে হবে পূজাটা নয় It's not for now.
Actually, why don't we start? Slides are up there. Oh, Abbas is doing it. Yes, we can see your presentation. Okay, so just introducing Mr. Ghazalfar, who is a very good friend of mine. He's actually a transplant and vascular access surgeon at St. George's University Hospitals and NHS Foundation Trust. And also Abbas is the head of the clinical teacher section at City St. George's University of London. He's a very accomplished surgeon, so he's really, really good as a surgeon. But also he's a very good teacher. He teaches medical students quite a lot. He teaches the third-year medical students, has been doing that for a very long time at St. George's Hospital. He does some special projects with the students. So maybe in Abbas's presentation you will see a lot of things that he has done with the medical students, which has been presented in national and international conferences, has been published, etc. So Abbas, over to you with the title of Expanding the Deceased Donor Pool for Kidney Transplantation.
Thank you very much. Do you see it in presentation mode or do you see it in...
Still in the
It's
non-presentation
not in slideshow mode. It is not in slideshow mode.
Not yet, Abbas.
Yes, now it will be.
Oh, I forgot to mention, Abbas is now actually the joint care group lead for renal and transplantation unit at St. George's University Hospital and NHS Foundation Trust.
He's clicking the right toolbar. So why it is not here? It has become.
Shall I start?
Yeah, it's not in the presentation mode, so you have to move the slides on the left-hand side, Abbas. And most of them are deceased donor transplant, and we are constantly trying to increase our deceased donor number of transplants. We were at a peak of about 180 before pandemic, but since then it has gone down. It's mainly because of availability of organs. The other thing that a challenge that we are facing is the living donor transplantation. So again, the numbers in the United Kingdom of living donor transplant is also going down. And this both deceased and living donor, we are seeing it despite the fact that we have gone from opt-in as a national policy for deceased donor transplantation. In other words, everybody had to say that they're going to donate their organs. We have gone into an opt-out program. In other words, everybody is presumed that they're going to donate a kidney, heart, lung, etc. after death, unless stated otherwise. So that came into force a few years ago. I can't remember. 2020, as Sister Maria Fernandez is reminding me, she's a transplant sister. But that has made no difference to the number of deceased donor kidney transplantation, which is kind of weird because we had seen that in Spain that the numbers went up quite nicely, but in the United Kingdom it's not going up. So there are some barriers still there, which it's difficult to overcome. So hence, what are the other ways we can expand the deceased donor kidney transplant? That's the question. And that's what Abbas is going to highlight on. Abbas, do you think you can present in this mode? Because I think it's not going to a view mode. Is that all right?
Yeah. Can you see my slides now?
We can see your slides, but not in a presentation mode. But that's okay. We can still see reasonably well. It's difficult, a little bit difficult to read, but you can see it.
One more thing in India is different from your set of donors. That is, your deceased donors are mostly metabolic insult. You have road safety has gone to a place that you have minimized the trauma-related donor. And we in India still now our donors are mostly BSD. They don't come from neurological ICU, rather from Rajat unit. That is, we get relatively younger, less complex donors. And you now get more metabolically challenged deceased donors.
So that's an important thing Urpita has highlighted. The donor age here is much younger than in the United Kingdom, and they do not have any other metabolic problems such as hypertension, diabetes, overweight, heart disease, etc. But the deceased donor pool in the United Kingdom has become more obese, older, diabetic, proteinuric, all sorts of things. So yeah, that's a challenge. So Nick,
we have to improve the kidney metabolic syndrome in order to improve the quality of the donor organs that we subsequently give.
So Dr. Anil is highlighting another advantage of managing CKM is to get good donors. That's a joke, but on a broader thing, it is our duty to improve cardiac and metabolic care in our patients so that people remain healthy and achieve their potential, not necessarily being a donor, but
So can you see my slides moving into the next?
Okay, let's move to the next one. Abbas?
No,
No, it's not moving.
No, it's not. So he should send here and they will project for him.
Can you see it moving?
No. No, it's not moving, Abbas.
The presenter view is there.
So do you want to try the presenter view on top left? Does that work?
Yeah, I have got it.
No,
it's in my screen, it is moving for some reason, it is not on your screen. I have also emailed Arpita my slides just as a backup yesterday as well. So.
Okay, let's get
You email me.
Yes, can you email it to IPGMER email.com. Abbas, we are doing it and we'll get your slides very soon up.
Yes.
On the screen, hopefully. So what we are doing is we are sending from Orpita's email to another different email. Anybody wants to ask any questions about deceased donor transplantation when we are on the
I have sent it to nephrology.
Yes, sir.
Is that the presentation? Abbas, can you see our screen now?
I can, yes.
Can you see your slides there?
I can't see that the camera is towards the audience rather than towards
slide. Can you turn it to the screen so that you can see that? Edit to carefully then. Can you see now? Above?
Yes, I can see it now.
Excellent, fantastic. So let's move it to the next slide, please. Oops. There you go. Thank you. So
that hardly I have heard ever such a good surgeon teacher. I think in my medical school days only. Very nice. You made it evident for St. George's.
Any
Actually, I was going to steal our Peter's question, which he was asking, was how have you managed to get normothermic perfusion available widespread across the UK to retrieval teams?
Yes, I was asking this question to me.
So, Nick, that's a very important and interesting question. So, that is a national resource. So unfortunately, in the UK, the problem at the moment is the machines are owned by centres rather than NHSBT. So we have got our hypothermic machine perfusion. We call it as an elephant tank, but we will not even give it to the other 4 centres which lie within M25 because of kind of obviously it is being purchased by us. So why we should give it to someone else? And that is kind of a thing which happens. So ITD in US or in Spain, so these machines are owned by a national organization. So they will then ship the machines to different centers. So ITD, when the organ is retrieved, it should straight away go to a normothermic or hypothermic machine perfusion, and rather than putting them in the static box, it should be the machine which should be traveling with the kidney to the centers. What we do at the moment is, as soon as the kidney comes, if we have got accepted 3 kidneys and one of the kidney we think will be long for ischemia time, or we're not happy with the perfusion, we will then put that kidney into machine perfusion. But then it might be traveling from Aberdeen, or it might be traveling from Glasgow, and there is already a 7 hours of cold ischemia time. It's not beneficial that much as compared to if the machine, the kidney is put on the machine. So coming to your answer, it is a national thing that needs to, it can only be resolved if NHSBT or national organization take ownership of that.
Thank you. Which is Dr. Pooja Banerjee, and she will be presenting on donor optimization in renal medicine and critical care interface. And Pooja is working now as a consultant nephrologist in a multi-specialty hospital in Kolkata. But I can proudly say that Pooja is one of our trainees. Thank you very much. Pointer is here.
So, good afternoon everyone. Thank you for the nice introduction, Prof. Devashish. So it's my immense pleasure to be presenting on this platform, on this prestigious platform today. So I will be speaking on renal medicine and critical care interface, and needless to say, it will be in the context of transplantation. So So these are some nice pictures of myself, and it's really a prestigious and nostalgic moment for me because I'm standing on my in my alma mater, IPGMER, when I left in 2014, and then in 2018, that's the picture on the left, when I moved to UK and joined as a registrar in St. George's. I'm carrying the dreadful bleep, registrar bleep. And then this is the St. George's, and then in 2023 I'm in the consultant office back in St. George's. So during my training I was fortunate to be for 2 years in St. George's, spent 2 years in St. George's, and the rest in Hammersmith and Guy's. And this is my last day when I was leaving, and it was Christmas time. So and I knew I would miss it terribly. So coming back to our topic now. So critical care and renal medicine interface in transplantation. So we know that a patient who is undergoing a transplant, kidney transplant, is very complex, often very complex. They have an extensive past medical history, they have specific transplant needs, and they have several comorbidities and polypharmacy. And sometimes post-transplantation, early or late, they get admitted in intensive care due to some organ dysfunction, and more so because of their immunocompromised status. And we all know that ICU on itself is probably not enough. We don't have many intensivists here apart from Dr. Raju. So they need to be supported by the multidisciplinary team, including the transplant surgeon, physician, pharmacist, and the infectious disease specialist. Most common solid organ transplant, but only 6% of the recipients, fortunately, need ICU admission in the post-transplant period. And this is predominantly in the late post-transplant period after 6 months. Commonest cause for ICU admission are the acute respiratory failure and the septic shock. And the majority of the diagnoses are cardiogenic pulmonary edema, pyelonephritis, pneumonia, and bloodstream infections. And we need to really, we do really worry about the impact of this critical illness on the graft life. About 40% of the recipients require renal replacement therapy when they're admitted in ICU. And half of the patients are discharged free from dialysis, but hospital mortality can reach up to 30%. The transplant characteristics are not the predictors of short-term survival when they get admitted to ICU. More often, the graft survival depends on the pre-ICU graft function and the disease severity and what we have done in ICU, including the treatment and the renal toxicity of those things. I've just summarized here, there is a dearth of study which have analyzed the ICU requirements for post-transplant patients. So these are a few studies which were done in France, UK, Greece, and European countries mainly, and also in States and Turkey, Brazil. And you can see here that they have seen recipients, varying number of recipients over a varying interval of time. And that gives at the, and that gives a percentage of 6.3% of ICU admission and a mortality rate of 30.9%. This is a recently published single center study on the critical care management following kidney transplant in the US, Augusta University. And these are the demographic characters of the patients who needed ICU admission versus the non-ICU admission. And you can see here that they are more elderly, higher BMI in people needing ICU admission, high percentage of males, more blacks, and in the terms of underlying kidney disease, although that is not always going to be significant in terms of correlating with the ICU admission risk, but hypertension and diabetes were the leading causes of end-stage renal disease in patients, high percentage in ICU group. And the indication in this study for needing ICU admission post-transplant was mainly hypertension, uncontrolled hypertension needing blood pressure monitoring, followed by hypotension episode, respiratory failure, ketoacidosis, hyperkalemia, and arrhythmias were the other causes of needing ICU admission. Now, quickly I'm going to speak about these causes of why they needed ICU admission. So, very important cause is hypertensive urgency, and it is very common, and sometimes they do need to be admitted in ICU for invasive blood pressure monitoring and management. And the total prevalence can vary depending on the units, but it can be as high as 85% post-transplantation. And definitely it has an association with shortening of the graft survival and cardiovascular morbidity and mortality. So what are the risk factors for development of post-transplant hypertension? So we know that people who have been hypertensive on multiple drugs, they often remain hypertensive despite good graft function. Elevated BMI, male sex, African American race, old donor age, those are the other risk factors. Now, among the transplant-related risk factors for development of hypertension, we have delayed graft function, acute rejection, chronic allograft nephropathy, transplant renal artery stenosis, extended peripheral donors, and the disparity between the donor size leading to the development of hypertension. There was the collaborative transplant study, which was a large cohort study of nearly 30,000 KT recipients, showed that there is a graded association between blood pressure and the allograft survival. Now, this is taken from a review article published in 2016 in the Chest Journal, which has nicely summarized the causes of ICU admission post-transplant. So you can see that main cause is acute respiratory failure in 45 to 55%. Then is the bloodstream infection or other infective causes leading to shock in 25 to 40%. AKI in 15 to 30%, and coma due to variable causes due to infective or non-infective like breast or encephalopathy or stroke in 5 to 20%. So acute respiratory failure. Half of the patients who are needing ICU admission, KT recipients, are needing so because of acute respiratory failure. And the common diagnosis is cardiogenic, particularly if we have less than 1 month transplant recipient, it's mainly cardiogenic. And 50% of those of recipients admitted to ICU within a month had cardiogenic pulmonary edema. The UK study showed that among those, hypovolemia was present in 30%, and it is an independent predictor of development of cardiogenic pulmonary edema. The other predictor for development of cardiogenic pulmonary edema is a delayed graft function or EGFR less than 45. There was a February trial, the post-hoc analysis showed that EGFR less than 45 can lead to development of pulmonary edema in association with hypertension and volume overload. Management, mainly diuretics, after reduction and NIV in most of the cases. However, 30% of the patients may require mechanical ventilation and 50% may require renal replacement. The mortality rate, however, is not that high, only 10%, but long-term renal prognosis remains poor. Now, there is a retrospective analysis of a large national registry by Shore et al., which showed that ATG, which is often used as an induction or to treat rejection, severe rejection, has been associated with pulmonary edema or development of ARDS, mainly due to the cytokine storm that can happen, and it can give rise to non-cardiogenic pulmonary edema. However, there is a lack of causal relationship between ATG and ARDS, as these patients who have received ATG due to rejection may be more ill and may have developed some infection leading to respiratory failure. 2 studies have tried to evaluate the cause of unplanned the predictors of unplanned ICU admission. So why these patients are getting sick and what can we do to help them from or prevent them from developing cardiogenic pulmonary edema early post-transplant. There was a study from Japan where 5.8% recipients develop post-op pulmonary edema, and they have shown that if patients have a pre-transplant poor LV dysfunction, diastolic dysfunction, and a high ratio of transmitral flow velocity to annular mitral velocity, which is a measure of pulmonary capillary wedge pressure, they are more prone to develop pulmonary edema post-transplant. There was a study from UK which tried to evaluate the role of CPET functional test to predict post-transplant ICU admission or respiratory failure, and they showed that the best predictor was a reduced anaerobic threshold. Standard pre-transplant resting echo is not enough to predict the future need for ICU. So this is the main common cause of respiratory failure in a patient post-transplant needing ICU. Now coming to the other causes, what are the other causes of needing ICU admission? So there can be perioperative complications. So 59% of the patients, according to an Australian study, experience at least one surgical perioperative complication, whether it would be surgical, urological or wound. But luckily, only 6% of those who develop these perioperative complications need ICU admission. And the dangerous complication of mycotic arthritis can be a life-threatening, which is a life-threatening invasive fungal infection, can lead to severe complications like anastomotic leakage, rupture and hemorrhagic shock, and Candida aspergillus are the common pathogens. Other perioperative complications like damage to the gut during surgery, contamination of the preservation fluid, they have been occasionally reported causing ICU admission. The perioperative hypotension. Often we have patients who are admitted in ICU because of perioperative hypotension and they need fluid management plus minus vasopressor and inotrope. Now, if we look at why they develop this, it is probably multifactorial. Often, in case of diseased kidneys arriving, we dialyze them pretty soon and with a short time gap, and they end up being volume depleted due to aggressive ultrafiltration to the dry lid. Autonomic dysfunction, poor cardiac reserve in diabetic elderly recipients, they are the other causes of development of perioperative hypotension. Again, using antihypertensive drugs overzealously can cause hypotension, and tissue ischemia with the release of vasodilator substances can also cause hypotension in the perioperative period. So prevention is key, and we have to resuscitate the fluid based on the dynamic indices, and patients who are unresponsive to fluid management will need inotrope and vasopressor in ICU. Now coming to infections. So I was hoping that Professor Shah will be here to talk on the post-transplant infection, but now that we are missing the session, I will probably cover this. So most common source of infection in a kidney transplant recipient is the lung, in 50 to 60%, and 2/3 of these pneumonia are caused by bacteria. And there is an association in one study between use of MMF and bronchiectasis, and that usually associated with Pseudomonas colonization, which means we should consider the antimicrobial regimen accordingly. CMV, pneumonitis, was historically leading virus in viral pneumonia in post-transplant. However, with the current prophylaxis, preemptive treatment, this has gone down. In a study from Finland and Germany showed that 1,100 recipients over 8-year period, only 3 patients developed CMV pneumonia. So very, very small fraction. Pneumocystis jirovecii is obviously a dreadful infection and most common opportunistic infection, particularly after 6 months when the cotrimoxazole prophylaxis has been stopped. And often there is a history of acute rejection being treated with augmented immunosuppression followed by development of this dreadful complication. Often the median time is 5 to 10 days between onset of symptoms to ICU admission. We all know that there can be severe hypoxemia, interstitial, alveolar interstitial opacities, ground glass opacities on CT like this, and half of the patients need mechanical ventilation. Shock is less common, only in 10%, particularly if there is superadded infection. Fiber optic bronchoscopy and valve has the highest diagnostic yield. So we more or less covered the post-transplant pneumonia. Another infective cause needing ICU admission is obviously graft pyelonephritis. So if you see a kidney transplant recipient, in terms of infection, graft pyelonephritis is more common than, the incidence is more common than pneumonia. But if you see patients needing ICU, graft pyelonephritis follows pneumonia. And it can cause worsening of graft function, even graft loss, particularly if it occurs within 3 months of post-transplant. Manifests mainly as septic shock, less frequently as ARDS, and half of patients may require RRT during the period. Among survivors, dialysis dependence is common. The bloodstream infection incidence is 22 to 24%, and again, deceased donor, rejection, presence of ureteric stent, Charlson score, which is a comorbidity index score of more than 3, they are independent predictors of bloodstream. Pathogen-wise, gram-negative bacilli are the commonest, and source-wise, urinary tract, catheters, and abdominal source are the primary source. In 25%, we can't locate the source. Other pathogens, mainly after Clostridium difficile is within 1 month. Mycobacterium tuberculosis is within mainly reactivation in 1 to 6 months post-transplant. Nocardia, Cryptococcus, Toxoplasma is after 6 months. Now, how do we manage the immunosuppressive treatment during this ICU admission? Generally speaking, there is no consensus. Some studies have shown that we, in the presence of overwhelming infection, to avoid deterioration, we should stop the immunosuppressive drug, giving covered steroids. However, this has not been studied to have a mortality benefit. On the other hand, if we maintain the current immunosuppression during an ICU admission with sepsis or a respiratory compromise with pneumonia, it might delay the sepsis recovery. Also, there is a chance of drug-drug interaction between antimicrobials and immunosuppressant. And third, the shock and the acute kidney injury may alter the pharmacokinetics of these immunosuppressive drugs. So we need a very careful monitoring. The other cause of ICU admission, I am going to go through this very quickly, is drug-related side effects. Often patients develop side effects from the immunosuppressive drugs and become very sick and get admitted to ICU. So drug-induced neutropenia is common, and there is a study by Helen et al. Which showed that neutropenia carries an odds ratio of 2.34 for development of invasive aspergillosis. And among all immunosuppressive combinations, the use of mycophenolic acid with tacrolimus is more commonly causing neutropenia than other combinations. So that is the most common combination which most of us use. The other drug-related side effect which can result in ICU admission is pneumonitis due to sirolimus. So usually mild to moderate, this pneumonitis, but sometimes it can be acute, and patients may develop respiratory distress and land up in ICU. Now there is a rare complication only in 0.35% post-transplant, is posterior reversible encephalopathy syndrome. And these patients, when they develop seizure or reduced GCS or severe hypertension, they end up being in ICU. And they are mostly, this stress can be related to the immunosuppressive agents they are on, particularly tacrolimus and less frequently sirolimus. However, it is important to know that this neurological toxicity does not correlate with the drug levels. An MRI can, as you can see here, MRI showing the vasogenic cerebral edema is the diagnostic for PRES. Other drug-related side effect, TMA, can end up in ICU admission due to AKI, hypertension, and multi-organ dysfunction. And the incidence is 4 to 14%, mostly drug-mediated due to CNI and sirolimus. Others may be post-transplantation atypical HUS recurrence, ABMR, CMV, and malignancy. Now, other causes of ICU admission post-transplant can be electrolytes. So we have a functioning drug, there can be a lot of medication, new medications, and some old medications which are being consumed, and that results in an electrolyte disturbance, acid-base disturbance. So hyperkalemia, hypomagnesemia, hyperparathyroidism leading to hypercalcemia and hypophosphatemia are common. The single center study from USA showed that 2% of ICU admissions are due to decay and 5% due to hyperkalemia. And we know that tacrolimus more than cyclosporine puts these patients at risk for development of diabetes and subsequently can develop DKA. Hyperkalemia sometimes managed medically but may require dialysis, particularly in the context of DGF, and are often caused by CNIs and antihypertensives. Now this is showing the proportion of critically ill recipients requiring life-sustaining therapy. So you can see that NIV requirement in 30%, mechanical ventilation in 70%, vasopressor in 60%, and RRT in around 50 to 60% of the patients. So the take-home message from this, I would say, is that we should not delay admission to ICU, but at the same time, we should not routinely admit post-transplant patients in ICU just for routine monitoring and put them at high risk of infection, nosocomial infections. We should routinely assess cardiac function, mainly by the function test and if needed by low-vitamin stress echo to avoid the development of pulmonary edema post-transplant. Consider pneumonia, consider pyelonephritis, and consider bloodstream infection as being major reasons for ICU admission. We should evaluate risk for pneumocystis jirovecii if the patient has type 1 respiratory failure, and always look for BAL sample for a definite diagnosis. We should always consider drug-related toxicity, avoid nephrotoxic drugs and contrast agent, evaluate the graft by Doppler, and do a therapeutic drug monitoring. And also consider administering GCSF factor to severely neutropenic patients. Thank you so much for your patient hearing.
Thank you very much, Pooja. Any questions for Pooja?
What do you think is the top tenovirus TTS with regards to understanding the depth of immunosuppression?
Wow, that's a very interesting question, and I don't know whether I know the answer to that. We talked about it. I have maybe Peter would like to comment. What do we monitor
not
to?
using it, not using it,
Not in use,
but not using it.
theory wise we have.
My fellow colleagues, they are telling that they are using it, and that is becoming useful. It is to get an idea of the immunosuppression when treating an infection, that you should, how much you should decrease. So top tenovirus can give you, estimation can give you that idea, and I think the centers which are high volume centers like Pratik Center, they are using in few cases top tenovirus. So I have not personally used it.
Yeah, what I would say, luckily at St. George's the infection rates are pretty low. Recently we analyzed, I think our last 1.5 years data by Roshni Patel, which showed that again the infection rates are low and ICU admission very low, death none. But there are some patients who are usually diabetic, older patients with other comorbidities who have a slightly prolonged length of stay if they have an infection. So infection does cause some prolonged length of stay, but no ICU admissions and no deaths, luckily at least in the last 1.5 years. So that's why we don't do any extra monitoring or immunosuppression. As you know, I don't know whether you remember, we do have a very measured immunosuppression. So we give basiliximab, tacrolimus,
steroid discontinuation.
and we continue the steroids at stage 7, only the low risk patients. Otherwise we continue the very low dose and no ATG. No ATG, so we don't give any anti-thymocyte unless you know you've got antibody mediated rejection and the steroids in the first instance.
What did you do in a second transplants, and there also you don't use ATG?
No. So this is, let me be clear. Nothing ever in St. George's makes us use ATG as the first immunosuppression, other than as you know, basiliximab on day 1 and day 4. Nothing.
You match the HLS better than we do.
No, that's not true. We do take risks. We try to. So for example, if there is a high risk pair, live donor pair, we go for a kidney sharing scheme and have a lower immunosuppression. And as you know, we have stopped doing any ABO and compatible transplants at St. George's.
So high resolution HLA, looking at the match of the, I don't think they do a plate match. A plate match we're not doing.
No.
So they don't go up to a plates. So high resolution HLA, and they are matching it as much as possible. Going to kidney share scheme if the patient is not having that much similarity with the, naturally if it is spousal donation, they are most likely they will not match, and the best thing is then to go for kidney swap. That is the thing.
Can't tell you. Sorry, that's you should have asked Abbas. I don't know. But as Ompita is highlighting again, the kidney sharing scheme has really helped us. We were doing the incompatible transplants when Nikos was with us. I can't remember, that must have been between 2009 to 2015. In the last few years, zero. Because of
that's why learning from the global scenario, when I was in my presidency tenure, now this year I will end up my presidency tenure, I have emphasized the swap transplant as much as possible. St. George's staying experience also helped me in formulating that, and ISOT has come out with a swap software. Why? Swap softwares, the HLA matchmaker type of softwares, there are many in Mumbai, Shruti Tapiawala uses one, in Kerala, Firoz Aziz uses one. These HLA matchmakers are trying to give maximum match on high resolution HLA. through this type of software. But the public sector hospitals, they do not have, because this costs around 5L plus, and only private hospitals do buy, or the individual nephrologist on their own can buy that. So for use in public hospitals, in support with Chennai IIT people, we have developed a software. From nephrologist part, young nephrologist Dr. Shakti was very much part of its development. We were on the advisory board. We repeatedly have checked it in validation cohorts, and it worked nice. And it has been given to Noto so that if they allow the use of it, it can be given free of cost to the public sector hospitals, so that the public sector hospitals can do the swapping among themselves. Why it is important? Public-private sector swapping is bringing up problem. What problem? Suppose the private hospital has a cost of transport, and the public hospital waiting list people or the patient coming for, they might not have that rich monetary ability to carry on the transplant. They have to migrate to the public sector. They may go to some other state, because in South India people are doing like Mumbai, Karnataka, Mumbai, Gujarat, and you have to go with your patient because the organ is still not traveling from living donation. The organ is not traveling. So you have to go for swap. That's also a question, Debashish. What happens when you do far away swaps? Do your recipient go to the swap city, or the organ travels?
No, they don't organ travels, because only last week we had a donor from Portsmouth, right? We had right? From Portsmouth, and the recipient was with us. So kidney travels 3-4 hours, not a problem, even from Glasgow.
So till now in India, the kidney doesn't travel for living donation. So another input for my presidential donation, that swap, let the kidney travel. So again we will come into the HMP and NMP perfusion, which I was asking, and this year I was in ESOT, and I was looking that when NMP provision is not there, HMP is easier to get. So HMP with some oxygen bubbles, additional oxygen bubbles, can keep the kidneys performance even better. That one paper was there. Surface oxygen bubbles.
Thank you very much. I have a question for Pooja. I don't know, this is an answer you may not know, because I definitely don't. So at St. George's we have this tradition where Carlotta and Nicoletta do an invasive monitoring, putting an esophageal probe. And the question is, does that actually help prevent ICU admission? You may not know it. Maybe I should ask the next speaker the question.
I think Rajatha will be a better person to answer this, but avoiding ICU admission, transesophageal monitoring.
Does it help, Roger?
So I think we do a lot of dynamic hemodynamic monitoring, peri-transplant anyways, to optimize the fluid balance. Yes, but whether specifically transesophageal echo will help?
No, lung ultrasound I have made Rajat to do.
Transesophageal echocardiography basically requires the patients to be sedated, right? So the access route is the oral track. So you need the patient to be sedated. You don't want the patients post-transplant to be on sedation, on tubes. So this actually increases the risk. So it's more of focus and echo and non-invasive, like the quasi-invasive gadgets which are more common. And moreover, it's VTI based or cardiac output based devices which have taken the.
We have gone for many times POCUS type of.
POCUS.
POCUS and yes.
Transesophageal echo is usually not seen.
Yes, part of POCUS I am speaking of 5 types of POCUS.
What I meant was during the surgery.
Oh, during. Yeah. During the surgery.
During the surgery, it has its indications.
During the surgery, it has its indications. Definitely. During the surgery, it helps.
Thank you.
during the surgery times.
Thank you very much.
And of course, separately.
So Pooja, once
Particularly when
again,
you are doing with
thank you,
disease
I will
and
let
you want to keep the system little filled up, and then.
all right, okay. So the next speaker has already introduced himself. This is Dr. Roger Chaudhary, who is consultant anesthetist here in the trauma center, and he's going to talk a very important issue about donor optimization in the intensive care unit, pre-donation.
Who doesn't know Roger's past history? Myself and Roger, myself and Roger was very young then, just has come into, and we together had done a lot of work when we established the disease donation system from here. From learning to executing, lot of things we did together. So
Right, I'm in this
he worked as
15-16 years.
transplant coordinator. In between, he left us for doing DNB in critical care. Then again came back. When it was a dream for me that Roger would come back and we would increase deceased donor declaration, and I would be doing every week 2 transplants on deceased donor. That didn't happen only.
No, and also a special thank you to Roger because he's not after all a kidney doctor, right? So
special.
But on and on, but present till now. And he came long back.
No, my regards to all the organizers of the ISN TTS team for inviting me. It's my pleasure to speak in front of this August gathering. Though the odd man out, thank you, sir. So though the odd man out, but I'll just speak a few of my tenets of what are the keys for disease donor maintenance, how to optimize for the best donations, right? So I think my background is from anesthesia into intensive care medicine. So spending most of the time in intensive cares, and as you all must be knowing that here most of the disease donations, they are happening in the trauma care center. So I head the trauma care center. So that's my luck or bad luck or good luck, whatever it may be, but I do head that center, and I do have the impetus to provide few of the inputs into the disease donation program, right? So I would basically speak that this disease donation optimization, most of the things are not on RCT basis. I won't speak on RCTs, control trials, because this scenario you don't have much RCTs. Most of these are based upon experiences, extrapolation from intensive care practices. Most of them are observational studies, and definitely few are from demographic pictures, what I would speak on, right? So I'll speak a single slide on the physiology, and then I'll go into resuscitation part, and finally what are the pillars involved in the disease donation. So I'll speak only on the maintenance part. The rest, though the disease donor management, all the steps of disease donor, but I'm just highlighting the maintenance part for the sake of today's session, right? So mostly we are interested about these organs. So the perfusion is the main key. So donor after brain death, these are the probable organs which we are more considering about, right? So basically the brain death individual initially has some sympathetic storm, followed by basically as the ischemia progresses, basically we have end organ damage due to hypoperfusion, finally sympathetic denervation, and then hemodynamic instability settles in, right? So what I would tell all the residents that basically whenever we speak that we as intensive care physicians get a lot of calls from the emergency physicians. So a patient presenting to the ER, if they are transported early hours into our intensive care, probably we get an opportunity to have a good yield of the organs, right? If we are treating physicians don't know, but if the patient succumbs somehow, we are actually getting a lot of time windows so that we can save the perfusion, we can prevent the morbidity to the recipients, right? So that's why we always tell that in this physiology, if we can take the patient at the higher in the physiology score, probably we have much of window in order to do much better maintenance in the disease donor management, right? If you get a patient in a hemodynamic unstable, many a times we cannot conduct the apnea test even, right? So hemodynamic instability and the complications as they go on creeping, we actually land up in a very terrible state, right? We even abort the apnea test, we cannot go on. Whereas if you consider higher up in the stages, we get a lot of window, right? So basically, if we look into all the complications, we can highlight that what are our objectives of management, right? So these are percentages just from few studies I have got, from where we have got the percentage. It might vary from scenario to scenario, from different countries it can vary, but overall these are all the tenets, like hypotension, DI, like we are getting so many patients with hypernatremia, right? So many a times we cannot conduct the apnea test. Like we and Madam fought many a times with the neurologist that hypernatremia, whether it's a cause of altered cells or whether it's an effect of brain stem death, right? So hypernatremia. So we land up with DI, basically a lack of resuscitation from the emergency end, or maybe late presentation to the intensive care, right? You get a lot of arrhythmias, pulmonary edema, metabolic acidemia, hypoxia, seizures, hypothermia. So if we know all these complications, at least we can know that what all we are dealing with in the coming few slides. So donor resuscitation is a multitasking job, right? So if you are an ICU in charge, if you are looking after disease donor maintenance, it's not the patient but also many people who are involved in the team. You have to do that job role of communicating with individuals in all the team members, right? Starting from the pathology, microbiology to the other team members, calling the proper, you have to receive calls, right? So many calls you have to receive at that time, right? So it's not easy, like only the disease donor maintenance, if you consider, it's a big program which we run, and definitely I think only the patient, if you see, the patient's outcome will be benefited if the time to the donation is minimized. So that's why if this workup is not done properly, ultimately there will be delay in the disease donor management. So you go on maintaining, but you will succumb, right? So you cannot you go beyond like 48, 72 hours. It's not the desire of a disease donor maintenance team. So all this has to be done very fast, right? Like it cannot be done in the mode of a Sunday, right? It has to be always on the Monday mode, right? So that is what I want to tell. So all these team members have to be on the go, right? Lot of numericals, but what I want to tell you is that there is basically what we call a rule of 100. Right? Whenever we talk about the targets of maintenance, we talk about the rule of 100. Don't mug up all the numbers. These numericals are all from the texts. But basically, what we tell that keep an asystolic more than 100, keep the urine outputs 100 ml per hour, keep the PO2s above 100, try to keep the sugar 100% normal almost, don't allow a lot of high sugars, right? And try to get a hemoglobin 10, right? So these are the bolder ones which we call as the rule of 100. So rule of 100 is what we follow. The rest is actually what the desire is basically to maintain a proper flow, maintain proper oxygenation, right? And this flow and oxygenation along with the temperature, hematocrit, you can look at all these things. Basically the sodium values also. Sodium values are more correlation with the liver uptakes and all these things. There are a lot of studies in the liver domain. The gastroenterologists, they can tell more that sodium more than 155, the outcomes are bad, right? So liver, they have a lot of trials on those, right? So, and PCO2 definitely. So hemodynamics, urine output, temperature, oxygenation, sugars, hemoglobin, and few metabolic parameters. These are all our physiological endpoints. But in short, rule of 100. CVP, let me tell you, like when I was doing residency in DRNB, 2018-19, around that phase, it was like CVP was taking a back foot. When we were giving the exam, CVP took the upfront. Like CVP was trying to, like we are losing CVP, but again CVP is again in the forefront. CVP is actually like it's almost a limit of fluids, right? So CVP again has come up in the forefront. So central venous pressure definitely has a role. In today's literature, in today's bedside practices, central venous pressure definitely has a role, right? Coming to inotropies. Now, somebody hypotensive with hypernatremia, vasopressin is the first choice, right? But hypotensive without hypernatremia, maybe you can think of dopamine, noradrenaline. Studies are quite gloomy in this aspect, but definitely noradrenaline intensivists are more in favor of noradrenaline because like you have sympathetic surge, a lot of tachycardia with dopa. So that's why norad still scores first, but the literatures more are in favor of vasopressin if there is hypotension with hypernatremia. If there is hypotension with the normal sodium level, you can even consider dopamine, norad, whatever you consider, it can be okay. But yeah, try to don't allow too much of tachycardia, right? So that is it, because like there's a lot of afterload failure, so that's why the NORAD actually has taken a forefront over dopamine in today's era. But vasopressin definitely, I tell you, but most of the patients they come with hypernatremia. At least in our intensive care units, we find almost 80% patients they have hypernatremia. Maybe we get late from the emergency physician, maybe, right? So hypernatremia, we get sometimes 175, 80. We cannot conduct apnea test. We first have to resuscitate.
Sometimes you start with NORAD and next morning you find the hypernatremia is in. So it's if the vasopressin can support the hypotension.
No, definitely vasopressin has come in. But the only thing is that like vasopressin has an ischemic effect on the heart.
Yeah.
So that is one point only, right? Where we as a metabolically weak continent, we actually keep vasopressin at the second. We are metabolically weak. We don't know how many of you are ischemic, right? That is the problem, right? Now there is a fight between a ventilation team. There is a pulmonology of the cardiothoracic team and the nephrology. It happens like the nephrologist they tell you keep fluids, and the cardiothoracic team comes and they tell that you diurise. Right? So that balance job is again to be done by the intensivist. Basically, we try to look upon the dynamic indices. We try to look upon the optimization of the physiological endpoints of perfusion. Right? So I think the cardiothoracic people, even they call from south, and we get calls from across India. That they always ask that what is the intake output, why are you considering fluids, why are you giving fluids, why are you not diuresing. So these problems they creep up, right? So basically the cardiothoracic people, they are more fond of keeping the lung dry as much as possible. They actually ventilating they want this lung protective ventilation, 6 mils per kg, even 5 mils per kg to be good, right? They demand some CT scans, CAT scans of the thorax. Many times patients are unstable. We cannot do the CAT scans. We fail to do. But even if we fail, the team members they accept, and maybe looking into the history, looking into the clinical context, they do accept. Right? They look into the pulmonary mechanics because ventilator is also monitored. So the ventilator parameters, the pressures, the volume, the flow parameters, which we communicate with those members. Usually, like our center has done lung transplants, but our experience is just like it's very, very, very thick, right? 2 lung transplants we have done, but very thick. Most of the lungs and they go to south and all this across India it goes. So we get a lot of phone calls. Like you have to do a CAT scan, you tell us the mechanics, you diurize. So all these things, starting from the chest dimensions to everything, they want to get over the phone, right? So this happens. Now, this bronchoscopy definitely, and all these things are important factors, right? So these are all the parameters which we need to take care. I'm not going into the details, right? Electrolytes, as I told you, due to this loss of HP axis due to ischemia, there's a lot of this sodium potassium imbalance, calcium potassium phosphate. Secondarily, it takes once this osmotic diuresis more, like if there is hyperglycemia and all these things, more of osmotic diuresis, further loss of electrolytes. These things we do have to keep in mind. And like as I told you that we many a times we fight with the neurologist that the hyponatremia, if they're, I think they won't go for carrying out the apnea test, right? So sodium is the most featured among all the electrolytes, right? Right. Temperature management definitely, I think it goes beyond doubt that temperature management by warmers, warm fluids, arrhythmia preventions, definitely coagulopathy, it avoids this coagulopathy arrhythmias. Definitely temperature management is done. Now coming to this important part, like this hormonal resuscitation which we tell, right? In our part we don't get T3, right? We gave actually oral therapies with levothyroxine, almost 300 to 400 micrograms of levothyroxine, enterally through rights to be given. But recommendation is basically 20 mics of levothyroxine LT4 with almost 4 to 5 microgram per hour of infusion of LT4. But we don't get it here, intravenous forms. So that's why oral levothyroxine is being given. Coming to methylprednisolone, usually 1000 milligram of maximum of methylprednisolone. Usually it is administered once the sample for tissue typing is taken, right? Because basically methylprednisolone has the tendency to reduce the HL expressions. So that's why methylprednisolone is another drug. Also it has a role in this hemodynamic improvement also, right? And thyroid hormones definitely in a like LVEF less than 45%, you go on with giving levothyroxine very early. Even like the first BSD declaration, you are going on the first phase, you try to give LT4 even then. Because if the EF is less than 45%, the recommendation is to give LT4 very early. Right? Coming to this glycemics, glycemic control, as I told you, high glycemia is absolutely not good because it will cause a lot of osmotic diuresis and a lot of electrolyte disturbances will creep. Right? So, and vasopressin, as I told you, hypernatremia, hypotension, vasopressin definitely. And many a times, like even like if there is no hypotension, we start on with vasopressin because like vasopressin in the hemodynamic guideline is like 0.04 unit per minute. But in this hormonal resuscitation guideline, we can give even at 0.01 unit per minute, right? So the dose can be reduced here because it's an hormonal resuscitation, right? So these 4 drugs are basically the hormonal resuscitation pillars, right? Extremely important because this has an impact on the hemodynamics, right? This has an impact on the hemodynamics. Inflammation, definitely, we are in a pro-inflammatory state. A patient who is succumbing, like almost like in a DVD case, like we have a patient, but these are all, no trials have proved that these are helpful, right? So that's why, apart from steroids, we don't go for all the fancy things, right? We just keep a note that, yeah, inflammation is going on, but steroids is the only one drug which has evidence and which we give. But others, we try to keep secondary, like we don't give therapies for all these drugs. All these modalities, this ECMO and high frequency, they are all actually outdated, right? They are not ECMO, but like high frequency oscillatory ventilation. At one time they were there in the disease donation, but now APCs and they are all out, right? So basically, I'll just conclude that disease donation management, if you look into basically the hemodynamics, ventilation and hormonal resuscitation, these are the basic pillars which are actually helping in maintaining the end organ perfusion, right? And if you give an end organ perfusion to the fullest, I think the recipients are happier, the teams, whoever are helping you out, will help you out for the second, third, fourth, and it will continue. So that is why this is the basic link and is very crucial link between the patient and the recipient. Thank you. Thank you for the presentation.
Thank you very much, Rosu. That was really fascinating because we never get to see this, right? We just see the organ when it comes to what takes to maintain that. That's very good.
Almost 1.5 days almost. Almost 1.5 day. Almost 1.5 day.
Also, I didn't realize that it's fascinating. You keep everybody calm. The cardiac thoracic surgeons, the lung doctors, the kidney doctors.
Yeah, it is from anesthesia days. like from anesthesia days. I think we are immune to these things. Like we deal with so much.
And you don't get angry also.
That time it was to manage the angry surgeons, angry high ego surgeons. Now they are managing the multiple.
No, we used to stay at 2 o'clock, 4 o'clock in the morning hours in order to meet the neuro and the cardiologist, saying that hey, see, we have to carry out the process. Please help out. We are there at 2 o'clock in the morning.
Fascinating, being so calm. Sorry, I don't think I can do that job.
I am privileged that even as a nephrologist, as I was, I spent those sleepless nights with them also.
Sometimes also working as a TC, transplant coordinator job also.
Really? Yeah, because everything has to be done in time.
Yeah.
All those things.
Initially TCs are not there.
Initially the SOPs, and I should share some words. Initially the SOPs were not there. So whenever sporadically things would come up, just to keep things going, we had to overwork. But we were in maintenance, and I can remember even in the COVID period, I took a lot of anesthetist, intensivist people's training in maintenance, and lot of online sessions we did with multiple hospitals so that we can graduate them to NTRCs, non-transplant organ retrieval centers. So I used to call up all of them were outside to please deliver this lecture in the online session. There will be a 4-hour online session. I myself in that period got trained by the Spanish coordinators, their system. So at that time when we don't go out much during COVID, so they offered the online courses and I did up till the advanced. So I also did coordinator training. I did this maintenance training where anesthetist intensivist training, because this was not there at all, Rajan. This was not there at all.
Fascinating. Can I ask you a question? It's really a very silly question. How passionate do you feel? Because this is not your
intensive care itself is a job of it needs a lot of time spending, right? Because we don't get the result immediate, right?
It needs a passion.
The intensive care itself, what I told you, that I am from anesthesia, from the OR, then into intensive care, and then into this domain. So actually, it needs a lot of time, devotion. Otherwise, you won't carry out this job role, I think, to be truly speaking.
Rajat, made to convert one no to yes after 36 hours.
So the passion is there.
Passion is there. মনে আছে রজত? 36 ঘন্টা বাদে তখন ওই বাড়িতে গিয়েছিল আইটি।
Guys at the back, the kidney doctors.
In the case of hypernatremia, to maintain the map, you would prefer vasopressin or you would still worry about the heart ischemia or the tissue ischemia you are having?
Hypernatremia with a normotency, the pressures are normal, right? Now I think,
Suppose it is borderline.
right.
You are going to start NORAD, but would you prefer vasopressin?
Yeah, vasopressin first choice. Vasopressin will be first choice, then maybe NORAD, right? But many a times it happens that patients may be prior on NORAD and then patient has succumbed, maybe patient was in a sepsis or septic shock, then has now translated into a productive donor. Now maybe an addition of vasopressin is desired, right? So NORAD creeping to 0.3, 0.4 mics per kg per minute, we add on vasopressin. Otherwise, a de novo case with a hint of hypernatremia, start with vasopressin first.
And what about antibiotics? You stop them altogether?
No, antibiotics we continue. In fact, we do send the microbiological evaluation, and even if the biofires and the PCR based reports. So if the PCR based reports, they can throw out some genetic elements into the microbiology profile, we immediately start and we convey to the recipient, all the recipient ends, that you try to continue with those antibiotics, right? Understood? Yeah.
Actually,
our reports are coming.
Rajat, the void area now is so much common is the donor infection over here, and the fright over the donor infection. Whenever the count goes high, it is also due to the brain death related inflammatory cascade. The count goes high. There are many such things for which the steroids that can also give rise to high counts. But with those counts, such a organ discard tendency is so high in our population that we need to make a protocol, Rajat, that what are the things that we would look for, what are the investigations we would send, and wait for the feedback. And over last 36 hours, how will we follow up that whether the infection responded to the antibiotics you have given or not.
Also, one thing to keep in mind that these PCR reports has to be looked upon into the clinical context, because PCR reports, they throw out all sorts of organisms with all sorts of genetic elements. So if you think that your unit is colonized, think that you has to take a hint that okay, my unit is colonized, this patient's tube or maybe bloodlines may be colonized, and so if the patients are not requiring high oxygenations, you target the organs, you try to convey the recipient end that no, nothing to worry. You try to continue with it. They think that this patient might be infected and so on and so forth. But these PCRs, they give a false sense that so XYZ organism with ABC genetic elements, and then all this goes to various centers. I tell that we are from public sector, it can happen. From public sector, we don't deal with a lot of colonizers in our unit, right? So try to be in the clinical context, that is also one thing.
So the clinical antibiotics would be on the local
Yeah, definitely. And
this empiric may change when your ICU infestation changes, when you have to take that infection control measure. I don't know, in SSKN there was an infection control committee, Roger, which would promote time to time sending samples from all SC machines, vents and everything. Yes. So it may change. After 1 year, it may change. And in public sector, half-treated patients from many centers we do admit who come with infection, but we can't refuse. No? So in public sector, infection trend is little higher than the private sectors, and we cannot allow the ideal space, separation, people come in, go, and all restrictions are not that way imposed. Lot of people. So these things are there, it will remain. Only thing you have to remain vigilant. This is for my students also if they want to continue in public sector. This vigilance has to go on. That sending time to time, whenever suspecting a new infection, new organism, then look at that where in your hospital that organism can grow and can give your patient an in-hospital bad experience. That with the units which deal with transplant patients, post-transplant patients, they have to be cautious about it. And these clinical clues are very, very important.
I agree with that. In the present era of possible antibiotic resistance,
yes.
I like what he said. You've got to know whether this is an infection to treat, or is this the XYZ organism with A, B, Z, T genotype, right?
No, I get phone calls, whenever this report is thrown in the system, I get phone calls that, do you think the patient we cannot take. I try to explain them that no, it's not an infection, we think it's a colonizer, you can accept that, but you can also start the antibiotics based on genetic makeup of the microorganism, because you are putting a patient on immunosuppression after some time. So definitely I think you have to accept the reports, but don't reject the organ. Try to take the organ and start an antibiotics. I think that is more beneficial. In the context.
Sometimes signs of infection are also muted. So the transplant patient with so many immunosuppression may not get fever, may not get the typical signs of infection that should appear first. So that way everything counts. The clinical context and the donor-derived infection.
Right. So should we bring this session to an end?
Yes.
Thank you very much.
Thank you.
And we should have a photo.
We should all have a photo.
students come first, with them we have a photo.
And then everybody?
Then also everyone.
Yeah.
Yes, because
Please
they,
don't leave. We're going to take a picture for ISN TTS.
no student, they are also students, no? You two are students.
Yep.
First, just a second, please. Okay. Everyone visible? Shadi? Thank you. Okay. Okay. Ready, everyone? Smokey, wait, call me. Yes. Okay.
Do you want to take one of them?
Riya will send it to you.
Ma'am.
Yeah, I will take one.
Then she will do it.
Thank you. So we check the inside. Just do one by one.
আমারটা তুমি নিয়ে যাও আমার বাড়িতে
একটু one by one করে ভালো সবাই একসাথে করতে
স্যারেদের সঙ্গে ছবি তুলে দাও স্যারেদের তো পাবে না আমার প্রথমে দীপঙ্কর বলেছিল দীপঙ্কর থাকবে না তারপরে আমি এমন করে যাচ্ছি তারপরে বলবো না ও 5 তারিখ আছে করে দীপঙ্করকে আশা করেছি
আমি কাজ করি
না জয়ের শ্বশুরবাড়ি জয় তো আমি তাকে নিয়ে না এলে হোটেলে থাকতেন না বোনের কাছে অনিতা তো সেই বিয়েতে গিয়ে চলে she passed away while she was in ASN.
More. Okay.
Wait.
Whatever is pending, I think you will have 5 years to sort that out.
I have another idea.
You just look into the ISN mails or you are ISN member, International Society member, then you will be receiving the mails. I regularly, yeah.